We'll go ahead and call our February 27th meeting of the Benefits and Insurance Committee meeting into session. Sorry for the short delay, but we had to get both presenters sequestered and into another room. So everything's good and we're prepared to conduct our business. So at this point in time, Mr. Priest, if you would, please call roll.
Preble Acton. Rhonda Allen. Dr. Andrea Anthony. Doug Botery. Amber Brown. Shay Crowell.
Happy to have you.
Me too.
Holly Deering. Alan Farley. Mary Hickerson. Jeff Phillips. Shante Sherrill. Eric Tutobeni. And Bill Ketron.
Here.
Good to go.
We have a quorum, so we're now able to conduct our business. I will entertain a motion to approve the minutes from the January meeting. Is there a motion? Motion to approve. Have a motion to approve from Mary Hickerson. Is there a second? Okay. From Shay Crowell. Okay. Any questions, discussion? Seeing none, all of those in favor signify by saying aye. Aye. All opposed, motion carries. Next on the agenda is our financials. Mr. Elam.
Yes, sir. On the 264 fund, you will see for revenue, $7,281,984. In expenditures, you'll see $6,962,777, a difference of $319,207. That's under the calendar year. Under the fiscal year, you'll see revenue at $39,153,962, expenditures at $46,246,378, and that is a difference of $7,092,416. If you move over to the tracker, total enrollment was 6,267. Yeah. 266 fund. See your graph again, January a little bit higher than January of last year. For the month of January 2020, you see claims at $54,969.52. Compared to 2019, there was $44,809.43. And what I will tell you is on workers' comp, there was 11,000 of the 54,900. There was $11,948,000. OGI was $43,021. That was the portion. If you flip to the tracker on the next page, you will see year-to-date our claims. Year-to-date is $278,023.38. Year-to-date last year was $462,691.20.
That concludes your report?
Yes, sir. That concludes my report.
Is there a motion to approve the financial report? Motion to approve. Have a motion to approve. Mary Hickerson. Is there a second? Jeff Phillips on the second. Any discussion? Questions? Seeing none, all in favor signify by saying aye. All opposed, motion carries. Next we have the workers' comp, OJI stats, and OSHA report from Mr. Good, our safety director. Mr. Good, you're recognized. You're welcome.
Good afternoon. First off, I'd just like to remind you that January is the first month of the OSHA calendar year. So as I report the figures, January is going to be the first month, and it'll be compared to January last month. So there's not going to be really any difference between that for the year-to-date numbers. You'll notice that in the month of January, we had a total of 26 injuries requiring medical attention. That's the same number for the year-to-date. Of that 26, 19 of them had restricted days. 19 total were recordable, rather. 12 were restricted days, 5 were lost time days, and 2 were others. As you see on the next page report comparing this year to the 2 previous years, while we are up, it looks like from this report, I wanted to tell you that after as the claims come in and me reviewing the claims, there were quite a few claims that were 1 or 2 visits in the month, and then they were closed out. I take that to better reporting and following up, and people just following through on their injuries. So I think that's attributed to why we have a slight increase right now in the month of January. As you look at the next page of the report, that kind of follows through when we start looking at the incurred dollars. We incurred dollars for the month of January was $76,000 compared to the 2 previous years. And you can see how that number is down from the total from last year as the incurred dollars. So that's where that kind of, you can see that there, why it's a little bit less. It's a little bit less than $3,000 per claim. So. On the last page of your report, you'll notice we break out where those claims occurred. The Board of Education had 17 claims. The County General had 8, and the Highway Department had 1. And when we break those down within the County General, you'll notice that it was broken up pretty much all the way across the county. You had them in the Sheriff Department, EMS, PAWS, the Correctional Work Center, and even one here at the courthouse. We had an injury in the month of January. Are there any questions?
Alan Farley?
Dan, is there any follow-up? Is there any training like on the strain or injury by? Looking at what caused the accident and follow back up with that employee, and does that information come back to you?
Oh, yes. Well, we do several things. First off, when the report is filed, the supervisor of that employee has a supervisor report. They've got to fill that out, and then they review the injury. We've also got a new program going that's been going on for several months now with the Board of Education. I'm working with Mike Walls, who's Director of Maintenance over there, and also with Trey Lee over the Construction Department at the Board of Education for all their injuries. And on a weekly basis, I send them an update of what claims that have occurred or accidents occurred at the Board of Education. And then we meet once a month for an actual sit-down to go over those claims. And then what's happening is Mike is going out there and sending his people out on the claims that may have some type of physical contribution to the injury. For example, if somebody trips over something, is that something that we need to be looking at and follow up and do? We have some things where...
So there's corrective action and retraining of that?
Oh, yes, sir. Absolutely.
Okay.
Absolutely.
Any other questions? Seeing none, I'll entertain a motion to accept the report. Have a motion from Commissioner Allen. Second, Commissioner Phillips. Any further discussion? Seeing none, all in favor, signify by saying aye. All opposed? Motion carries. Thank you, Dan.
Thank you very much, sir.
Yes, sir. Next, members, that brings us to item number 6, which is our on-site clinics and bid presentation. Before I turn it over to Jay Brown, who will come up and handle this, I just want to say thank you. This is a very important decision for all of our county employees, and thank you for being here so we can make the best decision possible for the thousands of employees that will be affected by this. So at this point, I'll turn it over to Jay.
You can go ahead and go to the podium. Can I speak in just a minute?
Yes, sir. Mr. Elam, you're recognized.
Go ahead. I just want to say thank you for the people that turned in bids. Murfreesboro Medical Clinic, Cigna, CARE, ATC, Primus Health, Vanderbilt, and St. Thomas. If you've ever gone through a bid process, there's a lot of time put into it, a lot of work put into it. And from the onset, the Insurance Risk Management Department, we wanted to make sure that we did all we could to get as many players involved and to get a good, bring something to the table here. So we reached out for all of our resources. I want to thank Mayor Ketron, thank Mercer, and also my Insurance Risk Management Department for how hard they've worked to get to this point. It wasn't easy getting 6 people and meeting with them and just even to get them to bid, but they stepped up and they did a great job. The next thing I wanted to say is to get to these 2 proposals, we started a subcommittee without any voting members to make sure that, everybody who was a voting member saw everything at the same time and saw the same information. And the subcommittee was Mayor Ketron, Steve Sandlin, Lisa Nolan, Sonia Stevenson, Lynn Pater from the Rutherford County Schools, and Melissa Griffey. So I want to thank them also for serving on that subcommittee to get to this point.
Thank you, Mr. Elam. All right. Jay, whoever's up next,
Yes, thank you,
you don't need to come to the well. We'll just let you make your presentation from there. Be fine.
Thank you. And as Mr. Elam said, we had the subcommittee. We had 6 binders similar to this that we had the ability to go through with our on-site clinic team over the last month and a half, I guess it's been, since we received those. I've given you guys a couple updates the last month as to where we stood with the quotes coming in, reviewing those quotes. The subcommittee has been very helpful in going through this with us to kind of really try to prepare for this meeting to give you, distilling that down to just a couple pieces of information to allow you to really look through this during the time we have today and go through that. But mainly what we were looking at is we've started the process would be looking at ease of access was something that was important as you guys have grown as a county over the last several years. Opportunities for growth and expansion was another item that we really wanted to look at as we went through this. High quality medical care was also important. And then another point is reasonable cost. This was a big ticket item, so we wanted to look at costs, but also it touches a lot of the members of the county. So when we went through there, as Mr. Elam said, we started out with 6 different proposals. We met with the subcommittee the first time to go through the proposals, and the thought there was we wanted to look at everything that was available. So when we did the RFP initially, we looked at on-site and near-site facilities as we grow, looking at that expansion. So we did ask for everybody to give their creative ideas as we were looking for, all the options were on the table. So when we looked at those 6 options, the 2 that stuck out as really more outliers when we were looking at those 4 or 5 criteria as our kind of foundation to choose would be Cigna was one of the providers. And as we get into that, on the cost per proposal, they were the highest. So it's almost $3.8 million. So when we were looking at them, that was somewhat of a choice we wanted to look through. Is in the state of Tennessee, there were very few clinics that Cigna managed. I think it's really just their own employees in Chattanooga. But the cost was a concern there. The other one was Murfreesboro Medical Clinic. We worked with them in getting the proposals, looking through their quote, and essentially their particular proposal was mainly using their facility. So taking all the clinics, on-site clinics out of the schools and managing at the one location. And their cost was right around $3.2 million. So it was in line with some of the others, but we thought that was kind of too far the other direction. We want some, probably somewhere more of a hybrid of potentially some on-site and near-site. They're probably, when we talked to them, and they admitted to, maybe 5 years away from truly being a viable option for Rutherford County or an employer of your size. So as we went through the options, those 2 in that first session were 2 that we said, hey, we don't want to bring them back for the next session that we had. Now, we ended up with Premise, Care ATC, Vanderbilt, and St. Thomas. And at that point, when we looked at them, the committee had a lot of questions. And that's what we wanted. That was the whole point is, come to us with your questions. Let's make sure we have the numbers, apples to apples. And so at that point, Jake and I had our homework of here's some things we need to go back and research, make sure we're looking at everything like we were supposed to. And then we came back, I believe, 2 weeks later with that same committee and said, all right, here's the 4 that we narrowed it down to, and really the spreadsheet of what we wanted to look at, with the goal of really trying to narrow it down to a couple to bring to this committee for you guys to review. And so at that point, Jake really did most of that analysis of the 4 that we looked at. And I don't know if you want to go into more of the, when we really look at it, it was more of the structure. I mean, cost was important, but really, what is your idea between those 4 options, and how does that fit into what Rutherford County's looking for today, as well as maybe 5 years from now, because this is potentially a 5-year decision contract. There's a lot that goes into, a potential transition, so we wanted to also make sure we had room for any additional growth over the next 5 years. And so I don't know if you want to go into the spreadsheet of how we got from 4 to 2.
Thank you. So from the first initial kind of subcommittee meeting, we were able to narrow it to the 4, and the 4 were very innovative ideas. So we were very excited. So I think in the past we've done bids, we may receive 2 or 3. This time we had 6, which is a good problem to have, but also narrowing it down to finding maybe the criteria we're wanting to meet. That 2 weeks was vital. So back to, if you look at the top on this first page, the 5 kind of pillars they say you should look for when you're doing a clinic bid, RFP, is ease of access, good customer service, high quality medical care, reasonable cost, and one that hasn't necessarily been in place for Rutherford County members, the opportunity for growth and expansion. So as of right now, we have them on the schools, and the thought was, what does that look like in the future? This is probably a 3 to 5 year contract. So what do we want 5 years from now? What do we want it to look like? So if you look at the boxes, what is pretty neat is each of these vendors has their own kind of creative idea. So if you look at the top, so Premise has several scenarios. One of their scenarios, scenario 3, was continue doing what they're doing today. Scenarios 1 and 2 were a subset of doing something similar to today, except for combining certain facilities and maybe having 2, or finding a Rutherford County owned and or leased space to maybe get out of the schools. So they brought their innovative idea. If you look to the right of that, Care ATC, they're a wellness, a kind of a clinic vendor, but their partnership was with HCA. So their proposal, which I thought was somewhat innovative, was just have one site kind of in the middle of town. And for the tertiary experiences, they could use Care Now, which is owned by HCA. There's one on Memorial, one on Medical Center Parkway, as access points for the members. The problem with that was that the Care Now facilities are already up and running, and they're already pretty full. So we didn't feel right that if we took clinics out of the schools and said, just go to a Care Now facility, if they're at 85% capacity and 3,000 Rutherford County members show up, that's not a great answer for that, okay? So that was an innovative proposal. It's one that I think could work, but you've kind of passed the point where we want to make sure whatever solution the employees and members have doesn't prohibit access that they have today. So that brings us to the bottom 2 is St. Thomas and Vanderbilt. We'll start with Vanderbilt on the bottom right. Their proposal is basically to operate the clinics as they stand today. The 3 clinics in the schools, with the knowledge that they do this locally with Metro Nashville Public Schools. They have some Walgreens partnerships, and they're going to talk about this. So I don't want to steal all of their thunder. They're going to talk about this in the presentation. Willing to build a dedicated Rutherford County building in the future. So they have bought some land. There are concepts they have in place. I don't know if they're going to be able to give exact details on those, but there's going to be, feel free to ask your questions, but they are kind of partnering with the ability to build another facility. On the left is St. Thomas, similar model. One of their proposals was operate the clinics as they stand today with the 3 current, and for those of you who may be wondering, the 3 current are Stewart's Creek, Walter Hill, Blackman. Those are the 3 clinics as they stand today. one of their subsets of their proposals is they have a building on New Salem that is currently operational, currently in use. In fact, several of the subcommittee members had used that building before. It is state-of-the-art. It's been built in the last 2 to 3 years. They are willing, if we decide to go that route, from a phase 2 approach to close the Blackman facility if desired and allow Rutherford County to have dedicated space, a check-in and 3 exam rooms in that facility to service the Blackman area, okay? Why would they do that? The Blackman facility is the one that we have studied the most and could probably use the most improvements from a structural standpoint, from a aesthetic standpoint. So there is some thought about getting it off of school grounds and getting it into a more modern facility might make access easier and parking easier, things like that. Okay, so again, they'll present that in their proposal. The other thing that St. Thomas has that they is the mobile bus. So you have seen this at the wellness fairs. They have a mobile bus and a mobile mammography bus as well. And those we actually used in the, I believe it was last October, the wellness fair. We had people out there getting exams. They are willing to provide that to us, I believe 50 days a year that we could move to sites that we wanted to do wellness screenings and kind of doctor visits. So they're positioning this as they would operate as they are today. If we wanted to move the Blackman facility into a more modern facility, they have that option, and then the mobile bus from an ease of access. So we go back to these 5 pillars. You got to have reasonable cost, but what are the growth opportunities and what is the ease of access? Because as traffic is becoming worse and worse throughout the city, we've heard that. But the big thing we've heard from many people is it's hard to find parking sometimes for the clinics, and that's no fault of anybody other than parking's tough to find. And so how do we want, again, 5 years from now, as we're building more schools and looking at more schools, how do we want that to look? So those were kind of our criteria. If you want to look to the second page, we'll kind of tell you how we got to where we got at the end. So the original bids, you can see here, these are the kind of broken down by cost category and total dollar amount. So these were the original proposals from all 6 vendors. I just want to point out, the CARE ATC HCA partnership, $1.9 million. That number looks great. But remember, their proposal there was just one facility, right, with some access to CareNow facilities. So although the number looks good, we go back to ease of access and actual utilization ability. We don't feel like that was a great method.
And this will be the first time.
And this would be the first time. So this is something they were trying to get innovative with, and again, haven't actually had a proven model to do. Through the process, though, and I want to kind of tell you how we did the bid, we had to release this bid in November of 2019. We gave vendors roughly 2 months, I believe, to do their bid, so we gave them plenty of time. But when we released this, we only had Q1 and Q2 utilization data. Everybody knows your largest quarter of utilization is Q3. So throughout the process, we wanted to make sure that we were able to get updated data to give to the vendors so that their proposals matched reality. So when we got Q3 data, we were able to release that to all the vendors. The updated experience allowed them to kind of revise their bids to a more reasonable number. And if you want to flip to the last page, and they will have a printout of this as well, but the finalists were able to revise their bids. So if you notice, I believe Vanderbilt went from 2.3 to roughly 3, and St. Thomas 2.4 to roughly 2.9. In red are the things they updated. So with new utilization, they realized there are quite a few prescriptions being dispensed at the clinic, and they'll talk about that. They realized there are quite a few wellness visits, especially as that push, you all know your wellness plan, especially as the push happens late summer, early fall. So they were able to update their numbers, and these are the numbers that you see from an apples-to-apples comparison that allows us to say, all right, what is the clinic operating at today from a full 12-month look? what does Vanderbilt, St. Thomas, and everybody else think their cost would be as a full 12-month look, and that's what we narrowed it down to these two. Fully expecting that they're going to present to you, probably do a better job of explaining their concepts and even their budget process than I could, and allow you the options and the ability to ask questions and come up kind of to your own conclusions. But we wanted you to understand how we went from 6 to 4 to 2 and why we kind of did it in a way that we want to make sure everybody is being compared the same.
And so what we would like to do at this point is really have the two come in and present. That way you can ask them questions, get a better idea of what we've seen in the binders, because I don't know that we've given it, the best on a, sheet of paper. And then after that, allow them to go back to the rooms and as usual, give you guys the opportunity then to ask questions before we make any final vote. But if it's okay with everyone, we would like to give them that chance to present to you and let you ask them direct questions before we kind of get back together. I forgot who's going first.
Before we invite them in, because I'm assuming they will not have seen each other's bids.
Correct.
Okay.
Correct.
So so you're talking about us comparing apples to apples, and there's some pretty big gaps here that I'm just curious if you've already looked at them. Like, for example, on Vanderbilt, you've got $200,000 in technology and software and zero at St. Thomas. So when you've got those big offsetting gaps, and like the reverse is true for, there's internet connectivity, 36,000, other fee, 13,000, 150,000, and zeros on the Vanderbilt side. What are some of those gaps?
It's a great question. I had a similar question, and what I will say is I want to make sure they have the ability to answer that. They call items and categories different things. So if you look, the total technology is within about 40,000 of each other. It's just in different buckets. One calls it a technology fee, the other one calls it an other fee. So the hard part is everybody uses a different jargon, and when we did the RFP, we put these categories together to try to force everyone to at least answer the best they could. Not everybody wanted to fit it in the right buckets or could, but at the end of the day, what we kind of have here is the best we could by each category along with the total at the bottom, which we think is really the representative number. Because for instance, one calls on-site drug dispensing operational, one calls it under supplies. They're both pharmacy cost. One it's a different accounting mechanism. But great question.
Before they come in, just for my information, and I might have missed it, is this a 1-year proposal, a 2-year contract, a 5-year contract? What is it?
The way it's written is a 3-year proposal with 2 1-year option extensions. What we are trying to do is show you year 1, and then we can discuss they actually propose years 2 through 5 as well, but again, from a concise standpoint, we wanted to be able to show you first year, which usually is one of the higher ones with implementation costs, and then show you the escalators on top of that. But yes, it is a 3-year RFP with 2 1-year extensions, so we do assume it would probably be close to 5 with the partnership if it goes well.
Let me just kind of follow up with that. What is this committee's responsibility and assignment? What do we do? What do you want from us?
Today?
Period. What do you want from us? When they
What I expect out of the committee today, Commissioner Phillips, is that we make a decision today based on the information provided by the 2 that we narrowed it down to. So we hope that at the conclusion of this meeting that we will make a decision. Either we're going with Vanderbilt after their presentation or with St. Thomas.
Where does that decision go from here?
It will go to purchasing and then to the full commission.
Yep.
Purchasing, budget.
Budget,
full commission.
excuse me.
That's my understanding, because it was taken under advisement when it was opened up originally. So my understanding, is that correct, where it goes back to purchasing the second time?
If this committee makes one decision and forwards that one on, what if purchasing or the commission wants to see others? What happens at that point in time? Just as an example, if we threw all of this committee threw all this out and said, we want to go with Cigna, what would be presented to purchasing? And I'm not asking from this perspective, I'm asking from a county commission perspective. What goes out of this committee, just that one recommendation?
That will go out with a positive recommendation to purchasing committee, and then from there, any commissioner would be happy to review the information and go from there. But it's trying to educate 21 on a lot of detail. So hopefully they will honor and respect this committee for doing their due diligence and all the hard work and making the tough decisions for them, because most of them are represented. Commissioner?
I apologize if I should know the answer to this question and I don't. The clinics, when we get the report every month, are MedPoint. So is that owned by one of these entities, or did MedPoint not bid?
MedPoint's Premise. MedPoint's a name that the county owns.
County.
Named it MedPoint. That's the Premise bid.
Okay, so Premise didn't make the cut. Okay.
Anya?
Sometime back, this body made the decision to come up with a name so that when we change vendors, we wouldn't have to change the name of the clinic. So everything's branded by MedPoint, managed by Premise, if that makes sense.
Okay, we're ready. St. Thomas Ascension is up first.
If we're waiting on them to come up, I do have one more question. So if Premise didn't make the cut, and they've got the most firsthand experience than anybody, and they're telling us it costs 3.1, I'm nervous that somebody else can do it for almost $1 million less than that. You have any insight?
The revised, I think it's 3.1. St. Thomas is at 2.9, and Vanderbilt's at 3.05. So they're within $150,000.
Yeah, so
That's right. That was with the 6 months of data.
the last page should match what St. Thomas is going to go over.
We did
It's
too.
within, I did too.
And just one of the big numbers there is the pharmacy. Everybody had a different number for pharmacy, and we felt like that we had a better idea what the pharmacy was, so we wanted to make sure that someone wasn't penalized because they had a better number than somebody else. So the pharmacy numbers are all going to be plugged in the same, very close.
Mr. Ferguson, whoever you want to have come make the presentation, come to the well, and if you'll identify yourself for the record, and you're recognized, and you speak into the microphone. Identify yourself.
Christy Martin.
Miss Martin, you're recognized to make your presentation. You don't have to be nervous. We're good.
Okay. I'm not used to the whole televised thing here. My name is Christy Martin. I'm the Regional Director of Operations with Ascension St. Thomas. I'm a proud resident of Murfreesboro, so very happy to be here today. I want to start by introducing those with me today. I'll introduce Stacy Woodruff. She is our Chief Financial Officer. Sierra Bunn is our Director of Business Operations. And then Gordon Ferguson, our President and CEO, St. Thomas Rutherford Hospital here in Murfreesboro. I'd also like to mention Dr. Rand Hayes. He's not able to be here with us today, but Dr. Hayes is our medical director for our direct employer program within Ascension St. Thomas. He is seeing patients today, so I apologize for him not being able to be in attendance. It's a privilege to be considered as a potential partner of Rutherford County to provide on-site and near-site medical care. As we move through the overview of the proposal, please keep in mind that we're working off the assumptions made from the RFP. We assume improving access, providing women's services, as well as addressing acute needs and managing chronic needs are all of high importance. If there are any questions at any time, feel free to stop me as we move through the presentation. I want to start by giving you an overview of Ascension St. Thomas. Ascension St. Thomas is a trusted healthcare leader in Middle Tennessee. We have a system of care with over 27,000 square miles. We have 9 acute care facilities, access to 42 specialties, 116 locations, and that includes 100 primary care physicians and specialty clinics. 100 primary care clinics, and specialty clinics in Middle Tennessee. We have 11 sites of care in Rutherford County. We're an innovative organization excited about the opportunity to be creative and collaborative working with Rutherford County to bring the best care to its members. On your next slide, you'll see a map that illustrates our presence across Middle Tennessee, and I want to call to your attention the multiple Ascension St. Thomas hospitals identified. Not only do we serve Rutherford County, but we also serve the surrounding counties as well. The next map illustrates Rutherford County. We took a zoom in for a look at Rutherford. There are 11 sites of care in Rutherford County with a wide range of specialties. At our DePaul and Seton clinics, that's our locations on the hospital campus, we have cardiology, infectious disease, GI, neurology, pulmonology. We also have bariatric, general, thoracic, breast surgery as well, sleep medicine, gynecology, oncology, and surgical oncology. Our DePaul and Seton clinics is where we house most of our specialists, just for easy access there to the hospital. At our New Salem Care Center, located on New Salem Highway, we have our comprehensive heart failure practice there, cardiology, family medicine, internal medicine, physical therapy, and radiology services. And as part of our mission, we do care for the poor and vulnerable, and we also have our St. Louis clinic. It's located over off Highland Avenue. It's our family medicine clinic. You'll also see on the map that we also have close affiliations with the Kroger Little Clinic and Premier Radiology. These relationships streamline care for our patients and help us to ensure that continuity of care is not lost as treatment is sought. As we all know, Rutherford County is growing rapidly, so I do want to call our commitment to Rutherford County in showing you that, I guess, with our large investment to add 72 patient beds and our 4 OR suites to our St. Thomas Rutherford facility. The completion of that should be later this spring. Although we are a large, comprehensive health system, we always ensure patients are directed to the physician in their network, a high-quality provider, and a physician of their choice. To deliver a high-quality program, we plan to engage, educate, coordinate, and consistently stay focused on improving the health of the population. There are multiple ways that we engage with our patients. A few to mention are our patient portal, telemedicine, email, phone, and best of all, in-person, face-to-face visits. We will develop a schedule with Rutherford County to ensure in-person education is held quarterly. These education sessions could include topics such as diabetes, heart disease, mindfulness, and healthy eating. And these topics would be determined based on the needs of the member population. We will also rely on our robust advanced medical system to produce patient education at the time of service. In addition, we'll have the ability to push specific seasonality reminders. These would include things such as flu vaccines, annual wellness visits, and the importance of breast and colorectal screenings. Our care team consists of the physician, a nurse practitioner, physician assistant, medical assistant, wellness coordinator, and dietitian. This team will provide care coordination needed as prompted by our population health team. From our population health information gathered through Optum Analytics and our medical record system, we will identify group and individual action goals. High-touch care coordination will take place to ensure the plan is completed, the county's goals are achieved. We'll also use Vital Insight. Will be able to be used, and this platform will allow us to fully assess health risks, conditions, and compliance. With regard to quality improvement, we will risk stratify the population, and all clinic providers will receive a scorecard monthly. This will be used for one-to-one outreach with the patients. Measures will likely include hypertension control, A1C control for diabetes, colon cancer, and breast cancer screenings. We'll be consistently measuring quality as a partner in improving the health of Rutherford County members. The Rutherford County Employer Direct Program is designed based on over 10 years of experience delivering similar programs to our clients in Indiana, Michigan, Wisconsin, and other Ascension markets across the U.S. Our approach to managing the health of the Rutherford County members is based on best practices, proven with clients like Carroll Clay Schools, Fiat Chrysler, and others across Ascension. In 2019, Carroll Clay Schools placed second for the Health Value Award. This award is provided through the Validation Institute and recognizes employers that are reducing their all-in healthcare spend by 30% or more while improving employee health outcomes. Carroll Clay Schools are also on the list for 2020. Our program is dedicated to providing the same high-quality service and making the same impact in Rutherford County. As we move on to service implementation, our approach to this partnership is to assume what exists today and work closely with Rutherford County to develop a plan for enhancing the services provided. This would include assigning a dedicated manager who would be responsible for ensuring a service level where every patient feels important, heard, and a part of their plan of care. This all starts from the time they make an appointment. It is our commitment to provide an easy process for scheduling by offering online scheduling and direct access to the clinic. In addition to offering the requested services, we are also offering our mobile health unit to be used weekly. We will also provide additional access to breast screenings by building upon our relationship and offering additional opportunities for members to be screened throughout the year. To provide the breast screenings, we will use our mobile mammography unit. I want to introduce you to our Mission in Motion, if you see that on your slide. For those who have not seen this unit before, it's pretty impressive when you see that driving down the road. So these will be where our mobile mammography screenings would take place. Implemented in 2011, the mobile mammography unit has provided 23,000 screening mammograms to women in 31 Middle Tennessee and Upper Cumberland counties. Over 15% of breast cancers detected through the mobile mammography unit have been in Rutherford County. As we expand upon our relationship with Rutherford County, we will offer additional opportunities to members for on-site screening. Our goal is to increase early detection through access to breast health services and screenings, therefore decreasing the potential of late-stage breast cancer diagnosis. As I mentioned previously, our intent is to bring the health care to your members with utilization of our mobile units. So you'll see there not only a picture of our mammography unit, but also our mobile health unit, which I might add was purchased by the Christy Houston Foundation. We plan to utilize the mobile health unit to increase access points across Rutherford County. We will work with Rutherford County to determine the appropriate locations. Members will then have the ability to schedule their appointment online or call the clinic directly. The mobile health unit will be used for addressing chronic issues as well as addressing the acute needs. We also anticipate using the mobile health unit for specific initiatives such as flu shots and annual wellness visits, should the county be interested. There is a slide included in your presentation that gives you a glimpse into the mobile health unit. You'll see there we have 2 exam areas and 1 triage. The bus is staffed with a nurse practitioner or a PA, as well as a medical assistant and a driver. As we move into phase 2, we really want to focus on member access. While our focus in phase 1 was making a smooth transition for implementing services, we want to shift it to making the improvement about being accessible. Are we in the right locations? What can we do to provide a better service to the members of Rutherford County? We would evaluate the performance within the current Walter Hill site to determine if the location is most appropriate. Should the need for a new location be determined in collaboration with Rutherford County, we would engage and support where we needed to assist in that transition. In phase 2, we would also recommend relocating the Blackman Clinic to our New Salem Care Center. Should further needs exist, we would also assist in locating and standing up a 4th clinic site. I want to shift now and focus on our St. Thomas New Salem Care Center. Your next slide should have a picture of the care center for those of you who haven't seen it. It is located off of New Salem Highway. It was built in 2017. It includes primary care, premier radiology, physical therapy, and cardiology services. The cardiology services are provided by our St. Thomas Heart physicians. This facility is state-of-the-art, offers ample parking. It sits at the corner of St. Andrews Drive and New Salem Highway. On the next slide, we've included some pictures so that you can see the interior of the clinic. The space that we have available is located on the 2nd floor. It includes a spacious waiting room and with a defined check-in area, 3 exam rooms, patient restroom, storage, and provider office. We would also have a draw station available for labs as well. The New Salem space availability is illustrated there on your next slide. You'll see the floor plan. I realize it may be hard to read, but the clinical area available is 1,955 square feet. Once the date of occupancy is determined, we would have a fair market value assessment completed, and that exact rent calculation would be completed at that time. The estimated rent today would likely land around $60,000 annually. As we know, with the market here in Murfreesboro growing so rapidly, we would want to evaluate that and complete that fair market value assessment at the time that we determine the occupancy date. To make this transition work, we would relocate the staff from the Blackman Clinic to New Salem and keep check-in for Rutherford County patients separate from the New Salem patients. This would create a fast track for your members. And while we envision the Blackman Clinic transition in phase 2, we are open to a move as early as September 1st of 2020, if Rutherford County needs to make a move sooner than later. The final slide includes some highlights from our recommended budget. The recommended budget first-year investment of $2.9 million. This includes a Rutherford County clinic manager dedicated solely to the practices within your organization, associate salaries, benefits, operating expenses for the 3 current sites. So this does not include the New Salem opportunity that I mentioned. Mobile health unit being utilized weekly at sites of your choice, increased mammography, dynamic reporting that's concise and allows you to get a really detailed picture of your population, on-site dispensing for your on-site clinics today, and telemedicine services. I would also mention that we have agreed to assume risk for clinical and performance outcomes for this proposal. Thank you for your time today to review our proposal. We're excited about the potential opportunity to work with Rutherford County on this initiative. And I will now pause and open for questions, and then after we'll invite Gordon forward for some closing remarks.
So in your suite of offerings, I don't think I heard you mention virtual visits for the employees. So do you have that as an offering?
Absolutely. We're actually offering virtual visits free of charge to Rutherford County, no additional cost. Those would be done in the practice with the provider in the practice, as well as we have an after-hours option as well.
And one thing they have at Disney is a thing called Fast Pass. Does this create a Fast Pass in the ER?
Oh.
Just kidding. No, one thing that, as far as some of the programming, some of the services, one of the things I think would be good for our employees, I don't know if this is available or not, but, you know, of course, offsetting costs and, of course, early detection is important in anything that you do in healthcare. But like providing executive level physicals for detailed physicals like stress tests and other things to kind of see what is lurking around the corner versus waiting until it happens. Is that something that y'all would provide, or is that something that's included, or?
Absolutely. That is something that we definitely have the means to provide. We do not have that packaged as such today, but we could certainly provide that service for you. And that is something that our partners and many other ministries are doing, and we would love the opportunity for Rutherford County.
Lisa.
I'm going to ask you to kind of just repeat what you said on the New Salem, that if the county chose to do that, that would be an additional $60,000. Is that, did I hear that correctly?
Yes, ma'am. That would be an additional $60,000 estimated. That's not based on a current fair market value, but going on market rates, we would estimate that to be around $60,000 annually.
Mary.
Okay, as usual, I have a couple of questions. Well, more than a couple. I got 2 pages, but we'll start here.
Oh, goodness.
Some of them actually are going to be down to once we decide how are we doing, so I'll come back to some of those. But you kind of touched base a little bit on other companies or government agencies you've worked with. So just kind of, I saw that you had the schools and stuff, and I'm not meaning to put you on the spot, but do you just have a rough estimate of how long have you been kind of doing business with other government entities or utilities? How long have you, and I say you as the St. Thomas Ascension, been doing this?
So as I mentioned, we are going to leverage the 10 years of experience that Ascension has in this space, working with employers and government entities like yourself. Today, Ascension St. Thomas does not have a government entity that we work with in the state of Tennessee. It was very coincidental that this opportunity came up. This is something that we're very interested in being a part of and growing in this space, in this work. So I would say it's roughly 10 years from Ascension as a whole, and those best practices being established. They do work with the government entities. I know Indiana in particular has got some strong clients there. I believe the fire department is one of those throughout the state that they help manage. So.
Okay, and another question, getting down to actually being in the clinic, how will your provider in the clinic that day, seeing me as the example, how are you going to handle sending out, recommending me to go, referring me to another doctor? How are you going to handle that? Are you going to handle it that you can stay within our Cigna thing, or are you trying to funnel them
and I'm not meaning to pick, I'm going to ask the question to the next one too. Are you going to funnel directly to a St. Thomas doctor, or are you willing to, they may not be in our network, most of them are, but if they're not, are you willing to keep our guys in network, or are you focused on, I'm going to send it to St. Thomas doctors? Did that make sense?
It did. In everything that we do, even today, outside of this agreement with Rutherford County, it is a patient preference. Now, our physicians will always recommend where they see high-quality care, low cost, absolutely. And for the patient who's not concerned about which provider they're going to see, it makes sense to keep them within our system of care. Now, they will definitely consider Cigna, I believe is the health plan that you all have. Absolutely, we want that patient to be in network. So if that means sending out of the system for that reason, if there's a unique specialist they need to see, then we absolutely will send them where they need to go. Does that answer your question? Yes, ma'am. Okay.
Alan?
Kind of expand upon what Lisa said. So this proposal here includes our existing sites, but if the New Salem comes on in exchange for the Blackman facility, it would be 60,000, approximately, give or
Right.
take, additional to this. So,
That's
but
correct.
this proposal here is only as we have right now, not including New Salem.
That's correct.
Got it.
That's correct. Yeah, we worked off the assumptions and I guess the detail included in the RFP, and that's how that recommended budget came about. So it is based off of what you have today, and your patterns throughout your practices, the best we could tell as well.
Jay?
Good afternoon. St. Thomas Ascension is a Catholic hospital, correct?
Catholic health system, yes.
So does that mean that the entire system follows the ethical and religious directives as written by the U.S. Conference of Catholic Bishops?
Follow the ethical and religious directives, see if I can get that right. We do.
Okay, so what that means is that at all of your facilities, you do not provide women's services that are deemed unethical or immoral by the Catholic Church.
I would probably have to lean on Gordon to answer that more thoroughly as far as the hospital is concerned. In our practices, we treat any issue that comes through the door. We do not turn a patient away. So we stand firm in our belief about meeting the patient where they are. We don't have OB/GYNs employed with us. They're outside entity, and so that allows us to stay compliant with what's being asked of us to be true to our Catholic health ministry. But yes, we wouldn't expect that to impact care, if that's your question.
That is my concern, because I came here from Wisconsin, and I do remember seeing several news articles about the system there, and Ascension was part of that, where women didn't receive the care that they wanted.
Okay. Gordon, do you have anything to add to that, or you want to address it when you come up? Okay. We'll continue answering questions, and we'll come back to that one for more clarity.
Other questions? You got your hand on the mic. Go ahead, Mary.
I really think the big bunch of my questions I had kind of brought to before we sat down here, but just kind of for the purpose of your numbers that you have, and Alan asked this also, but they reflect our current clinic hours. And you've also noted on here that this adds to what we currently have, but you're also bringing in potentially the weekly mobile health unit.
Yes, and that is a great catch, and I apologize. This includes what you currently have today, but it also does include the mobile health unit being used weekly.
Okay.
At a site of your choice.
Yeah,
I
it's-
appreciate you bringing that forward, and telemedicine as well.
It's about halfway down the page in green at 156,000.
Okay, I noticed that was on there, and there was that, and I totally understand Alan's question, and basically we are doing apples to apples, and here's a bonus for the same cost.
Correct.
No, so,
Yeah.
another question, where do we have a, after-hours care with y'all? Or is there one available?
Right, so our intent would not be to establish an additional after-hours care specifically for Rutherford County, but we are affiliated with the Kroger Little Clinic. There would not be any type of, or there isn't today, I don't believe, any type of special pricing arrangement there. So our agreement with Rutherford County would kind of stand alone of that. However, our affiliation with the Kroger Little Clinic will allow us to just ensure that continuity of care is there so that we can receive records back and forth. There's a lot of interaction and work there to strengthen that relationship. We also have our Express Care location at New Salem. So that location is open from 7 a.m. to 7 p. Monday through Friday, and then 8 to 5 on Saturday. Obviously, we would want the patients of Rutherford County so that we could control that quality, not quality service, but really capture that information for the county and being able to control your costs. We would prefer them come to the embedded New Salem location, but for after hours, Express Care would certainly be an option as well.
And this may actually be a question for Ed. Way back when, our after hours would be where we could have went into the clinic in Walgreens. And then, and I'm just speaking as of right now, we didn't get kicked out of it, but when Vanderbilt bought Walgreens, they no longer honored the care we had. So did Cigna work out the plan that we could kind of go into the Kroger Clinic or the CVS? Is that something Cigna did, or was that something that we piggybacked with having premise? So, I mean, I don't need to ask this after-hour care if Cigna arranged that and not part of our current premise. Did that make sense?
If I understand you correctly, I don't know about answering the Cigna part, but it's not part of our premise health arrangement. They used to have an arrangement before my time with Vanderbilt, but they don't. But with the Walgreens, but since Vanderbilt bought them out, they don't.
Right. So basically what we have the ability of going to is something that Cigna worked on to for us and has nothing to do with premise. Okay. So I won't ask that again. Sorry about that.
Oh, you're good.
Sonia.
So if we opted to go into the New Salem site, would the hours of operation be for the county employees the same as the hours of operation of the facility, or would they stay the hours of operation at Blackman?
So I think they could definitely stay with the hours of accessibility you have at Blackman. That facility is open from 7 a.m. to 7 p.m. New Salem facility is. So we would have some flexibility if there was a desire to do something a little different. But yes, you could. Our intent is to literally, it would be to take, and it would make the smoothest transition, not to say we couldn't talk about something differently, but to take the staff that we have at your Blackman location and relocate them to the New Salem location. So I would assume that we would want to keep business as normal as possible for that group. And I bring up staff, so just so you're aware, we would, in that transition, be able to come in, interview staff, and bring those over that were interested and willing.
Amber, or either one.
So I know the adding in the mobile service weekly, that's a great benefit, but will we have that priority as you all continue to scale your business and gain other partnerships?
Absolutely have that priority. We've actually looked at this and really have the capacity to absorb this work. We want to be a strong partner. We have local ties to this community. It is to our benefit to make sure that's an exceptional service provided, so yes.
Commissioner.
Okay, I was adding up the staff resources, and it looks like you're committing 15.34 full-time FTE equivalents.
We took what was shared with us about the current staffing arrangement. We are not planning to increase staff, if that answers your question.
But you're going to match what's currently there?
Mm-hmm.
Are you taking into account the mobile staff? Is that part of that number?
The mobile staff is actually, don't believe, included in that. I can get Stacy to confirm. It's not included in that. We have a flat rate for the mobile health unit, and it's like all-inclusive. It's all bundled together. That staff would not be your expense 100% of the time. It would only be when that mobile health unit was running. So that's why that's priced a little differently.
Yeah, if I can insert, and Jay, tell me, make sure I'm correct on this. The number that we have in there at 156,000 is only as needed. It's not going to be that we're going to be, if we don't use it that week, we're not going to be charged that week for the bus. It's only as needed. So that number could go down depending on, you know, how much success we have with it.
You're kind of leading to my question, which is, so then the quote here, as it's been presented, this is every service utilized at its maximum. This is the highest this number will be. This number won't be higher than that based on utilization. That's kind of where I was leading with that, which was, you know, is it a flat per member per month number, and this is what we're budgeting, and this is what's fixed, or is it going to be a fluctuating cost?
No, we try to make it apples for apples on the quotes, and I think it'll be, that is, Lisa?
Per day. It's a per day cost, so it could
On the
go
mobile
up
unit.
On the mobile unit.
I'm talking about the whole cost.
Yeah,
for
The whole cost.
for the
That's what
whole
I was referring to.
contract. Right.
Yeah.
I'm just trying to make sure that all the costs have been accounted for.
That's correct.
Yes, I was answering, you said that it wouldn't be any more if we chose to utilize that bus more. It could be more. How many days is it budgeted?
Yeah, it's like $3,100 per day. So times 50 days is that number there.
Budgeted for once a week.
We budget for 50 days, which is once a week, kind of. But it's really 50 days. We could use it 7 days in 1 week as we get towards the biometric screening time of years. We could use it every day if it's available.
And I guess, so in staffing, that was part of my question, is that I had made a note that you mentioned earlier in the presentation about dedicated resources, and that's what made me kind of go back and look. And so on your last slide, the first thing you've got is a Rutherford County Clinic Manager. So is that one person who's responsible for making sure everything works like it should?
Right. As I say, that's one person. Also understand that we have another local person, which is an operations manager, that will also be overseeing that manager and assisting, as well as myself. So there will be many that will be definitely involved in ensuring the clinics are functioning as they should. We're meeting the targets and the goals that Rutherford County has. So, but there's no additional staff other than the manager included.
You've also mentioned on here the dynamic reporting. Is that going to be compatible with the Cigna reporting? Are you going to be able to fold that in as one report? Because I think that's something that our clinics have worked currently to try to make sure that we're capturing full information. So will your reporting system integrate with Cigna?
I don't know about a total integration. I'd like to learn more about that, but absolutely we would come to, we definitely have the tools to create whatever report, however we'd like to see that and capture whatever data we'd like to see. But I think we could sit down with the leaders to ensure that we're capturing the right data and putting in the appropriate
And Christy, maybe
report.
speak to the ghost claim or shadow bill that you would send.
Yes. Is that what you're referring to? I'm sorry. Yes, we have the ability to produce that same thing that Premise is doing today with Cigna.
And then, and forgive me if I've overlooked it, but do you have any kind of an escalator built into this contract so that it's one number? I know you've got an implementation number, and then you've got years 1 through 3. Is there an escalator built in for years 4 and 5, or is it the same number if we renew years 4 and 5?
I think, let me look
It has
back.
all 5 years on there.
I was going to say, I think.
There's year 4 and 5 is listed too, and it is higher.
We've covered all years, but I will tell you there is an escalator as we anticipate to give merit increases for staffing and those things, plus cost. Does that answer your question?
But that is included in the numbers here? Okay.
Yes.
Other questions? Going once.
I'll ask Gordon. Oh, we've got more questions.
All right, Commissioner, go ahead.
I'm sorry, I did have one more. You were just ballparking, if we do that fourth clinic, you were ballparking rent at $60,000. Would there be additional charges beyond just that rent number? I mean, I'm assuming there's going to be staffing costs, operational costs that will go into that as well. So it's really more than the $60,000 if we add that fourth clinic, yes?
So first, let me clarify, we're not adding a fourth clinic with embedding in New Salem. We would be moving Blackman Clinic over. So as we do that, your staffing expense would remain the same. You would have your lease expense, and the only other thing I can think about is just, exam beds and those kind of things. If we feel like what we've got at Blackman can be moved over, that's great. If there's a decision made to utilize what we have in the space, we could figure that out in the lease. That wouldn't be a significant increase by any means, but those are the only expenses that, as we look at this, that we could foresee.
Mary?
Okay, this does need to be asked. Online, do y'all have a means, an app of what, online, how can I go online and set up my username and password and make me some appointments or send my nurse a question? Do y'all have that, and can you kind of speak to that just a little bit for me?
We have what's called InQuicker. That is our platform for online scheduling. So Rutherford County would have its own schedule built within InQuicker. So if you're a Rutherford County patient, that schedule would be available to you. You would go online and schedule. Now, communication with your physician or care team would be through our portal, through our EMR that we use, our electronic medical record. Mm-hmm. But there is a online. Yes, ma'am. Yes, ma'am.
Other questions? Gone twice.
All right, I'd like to ask Gordon to come forward.
Yes. Hello, Mr. Ferguson. You're recognized in the well.
Good afternoon. My name is Gordon Ferguson. I serve as the Chief Executive Officer of St. Thomas Rutherford Hospital. I would like to thank Mayor Ketron and the commissioners for this opportunity to present this proposal to you. I can tell you that our team has worked tirelessly to put our response together. And my job this afternoon is, I was told not to mess up this presentation. So I will try and do that. I have been with St. Thomas Rutherford actually 22 years this month. It will be 15 years next month that I've had the privilege of serving as the Chief Executive Officer. So I think it's safe to say that I call Rutherford County home. Our two boys went through the Siegel system here and went on to college, and I'm glad to say are both gainfully employed. But my wife Cindy and I, we have just thoroughly enjoyed our time here. We have really been very fortunate to be part of a growing community, and personally to have the privilege of leading St. Thomas Rutherford Hospital and watching our system grow throughout Middle Tennessee. Many of you may know our hospital started, I think it was around 1927. We spent many years over on Highland Avenue, and back around 2006, 2007, decided that in order for us to continue to meet the needs of our community, we would need to move to our new location. I call it new, but in October of this year, we'll actually celebrate our 10th anniversary at the Medical Center Parkway location. That original investment was about $276 million, and then I think as many of you are aware, and Christy alluded to this, we are in the process of completing an $82 million expansion, which will add 72 additional beds, as well as 4 surgical suites. And then this will also allow us to expand our emergency room, Mr. Farley, by about 25 treatment areas. The building is one thing. What I think we are most proud of is our mission, and that is that we take care of all in our community, including those that are underserved. And I believe many of you may be aware of the various medical missions that we provide once a year here and then in other counties that we serve as St. Thomas Health. We are also actively recruiting new physicians. Not this past year, but the year before, I think we recruited about 45 additional physicians to our medical staff, and that's a combination of primary care physicians as well as specialists. And as we are in our current budgeting process for the next fiscal year that begins July 1, we've got a list of many other physicians that we feel are needed to serve this area. I would like to just echo Christy's comments about our New Salem Care Center. This was one of, I believe, 10 care centers that we have established throughout Middle Tennessee. But I'm pleased to say that I think the New Salem Center is the busiest, if not almost the busiest. And we've got great providers there, physicians as well as nurse practitioners, and I've really tried to make the care experience at this location something very different than you would find at your traditional physician office. As you well know, there's a lot more expectations from our patients who are consumers in terms of what they need and when they want it, and I completely agree with the question about the online accessibility, and I did have an opportunity to use that myself just last month, and it worked out fairly well. I've not told my regular physician I did that, but I wanted to try and see how that worked. You also may remember that when we moved to the new location, we went back to Highland Avenue, and with the help of the Christy Houston Foundation, opened the St. Louis Clinic. That was originally set up to take care of the charity population that we felt we had left back there at that location. But over the years, it has now become the training facility for our University of Tennessee Health Sciences residents in primary care or family medicine. So that clinic is just bursting at the seams, and it is available not just for the original purpose, but also for any individual that is in need of a primary care physician. And so I'm pleased that is something that would be available here. And then we also, Christy mentioned again the New Salem Clinic, but we are getting ready to construct an ambulatory surgery center adjacent to the New Salem Clinic that is in partnership with several of our physicians as well as our United Surgery partners that help manage those facilities. We feel that this is just another access point that would be available, and there are many studies that show that we can deliver care, just as high quality care at a lesser cost in these outpatient facilities. Regarding the question about the ethical and religious directives, we do follow the ERDs. I would think it's a pretty thick booklet, but there's one section in there that does deal with sterilization, and we have certainly abided by the ERDs. I will tell you that just in the past few years, there was a federal law passed that we had to make birth control meds available to our own associates. So we do that through a relationship with a third party, and I think that would address the concern that you had. I hope I'm kind of reading that correctly.
You are. Thank you for addressing that. I wanted to make sure that any woman who visited the clinic could get their contraception or Plan B or anything else. Thank you.
No, thank you. I would be in big trouble if I said we didn't follow the ERDs. So just in closing, we are excited about the opportunity to present this proposal to you. I hope you can tell based on our history in this community that we're not going anywhere, and that we feel that it's a privilege for us to serve all residents of Rutherford County. But particularly in this case, I think this would be a great partnership with Rutherford County that we could set up and then work together to see ways that we could improve the delivery of care to the associates of the county. Many of you may have seen our new television commercial with a tagline, "Your care is our calling," and we take that seriously. We realize that healthcare is an extremely competitive environment, but we keep reminding our associates that our number one priority is to take care of the patient, regardless of where they're coming from or what their condition is. We've got an obligation to make sure we're providing this community with the best level of care. I will be glad to answer any additional questions, but I appreciate the questions that have already been presented.
Questions?
I just have one.
Commissioner?
On the management fee, it says 50% is at risk. Can you describe for me what that means?
I'm going to get Christy to come up. They are much more familiar with the intricacies of the proposal. Christy, you want to take that one?
Thank you, and that's a great question. So within the RFP, there were some quality outcomes that we would further define along with Rutherford County should we be selected. We are committed to achieving those outcomes, and we are putting 50% of our management fee at risk should we not.
Alan?
Gordon, you were saying that the New Salem location in the future planning is for an ambulatory facility there, correct? I want to make sure I understood that. Okay. And I was just trying to give county employees a leg up in the ER. Now, high quality service creates great demand, so we appreciate it.
Amber?
So there was mention of just how busy the new location is. What's like the average in your peak time, the average wait time?
Wait time, I would say, we do have days, especially with our express care and fully seasoned, you've got walk-in volume coming in, that hopefully it's not longer than an hour. I'm just being very honest here, could happen, depending on the volume that comes through the door at one time. But typically, our waiting room, it was kind of comical. We built this huge waiting room, and then you walk in, it looks like we're not open. We actually had patients telling us that because we do get them back very quickly. So for scheduled appointments, they're back quickly. And Gordon is correct. It is a very busy care center. However, the space that we have allocated, we're very confident in being able to provide that. There's still plenty of parking. It would be your space for Rutherford County. It's a separate hallway.
And the waiting period waiting time wouldn't apply to the
No,
Rutherford
it would not. You would have your schedule just as you do today. So that would not, yeah, that's a good point. It wouldn't impact you at all.
Sonia?
That's what I was going to say, because we're going to have a dedicated space with our dedicated physicians and clinicians, whoever's in there. So we wouldn't be in with the regular population that are coming to visit the clinic. It would be a separate floor or suite for us, however it is.
Right. Let me clarify. The waiting room, and you'll see a picture in your presentation, and you all are welcome to come visit anytime if you haven't been there. It's a large waiting room. So the waiting room piece would be shared. However, our check-in counter is very large, and you would have a dedicated check-in person. And so that person would be responsible only for your patients. So they would work your schedule and make sure that flow is appropriate. But we typically, if I see 10 patients in the waiting room for our regular primary care patients, it usually means there's been an emergency or something's happened. So we get them back very quickly.
Doug?
Just two quick questions on the optional clinic is, of course, they're going to be a shared place for at the lobby, you know, for patient waiting. But once our employees go back to that area that is specifically for the employees, our employees, will we have dedicated clinical staff for?
Correct.
Or will they be sharing that clinical staff like priority for that clinical staff?
No, that is your clinic staff. So you could envision this such as maybe you're leasing space in an office building, your staff, your business, storage is separate, provider office separate. Yes, it's like you have your own wing within New Salem.
The price of this would be based on, it could increase based on fair market value of that property. So do you have a ceiling during this?
We do not. I mean, we would be required to work off of the fair market value assessment. Obviously, that would come through conversation with Rutherford County as to where we land on that number, but we would be required to make sure that we worked within that fair market value assessment.
That's going to add its cost over the 5 years based on that if we go with that option.
Right. You would be leasing space. So today, from what I understand, you've got a freestanding building. This would be going towards leasing a space. It would be like anything else you were to lease in town, honestly. Does that make sense from a legal and cost perspective?
Mary?
Actually, this is not really a question to you, ma'am, and I appreciate your time, but mainly to put it out there is if we move to New Salem, we're closing Blackman. Blackman, if you look at the 3 clinics we've got now, is the oldest, and I don't mean to say it's run down, and I don't mean it like that, but
higher maintenance, right?
high maintenance. There you go. Thank you for that. Because, you know, Walter Hill kind of got fancied up when they did some remodeling. Stewart's Creek went in as the school was built brand new, so it had space for that. Blackman's sitting in a portable, so we have to take into account that we've either got to keep maintaining or really fancy up Blackman or make the move. So not really at you, but we appreciate the option of being able to close it and move it. And when you're doing it, you're just strictly moving what is in that building to another building. And, you know, it may have not cost us very much to start with, but maintenance has cost us, you know, not astronomical, but more than it probably should have, because when you got old, you got to fix it. So just for information.
Well, and if I can also add, New Salem Care Center, being an Ascension St. Thomas facility located in close proximity, you know, it seems like a good solution. However, if it was the desire to go to a different location, we are absolutely on board with that, understanding that you probably will need to do something in the future.
Other questions before we move on? Well, seeing none, thank you very much, Mr. Ferguson. Thank you, ma'am, for a great presentation. We'll take all this under advisement, and we'll be back in touch with you. Thank you so much for your presentation today.
Little fine print there.
I know. It's like people like me that can't see a thing.
Members, if everybody take a seat, I know some got up and had to use the facilities for just a moment. I guess everybody want to stretch just a second before we get started? All right, looks like everybody is back at this point in time. Next, members, we have Vanderbilt to make their presentation. 5 minutes before we came in there and hit the gavel, I saw Vanderbilt's helicopter flying over. Hopefully, they were not rushing anybody on an evac. I thought they were just showing some force and flying the helicopter over them before the presentation. You know, but we want to thank Vanderbilt for coming as well. So if whoever's going to make the presentation, I would assume you are, sir. If you'll come forward to the well, you may want to introduce the folks that you're with, identify yourself for the record, and the floor is yours.
And I do have a few folks with me. My name is Troy Williams with Vanderbilt, and thank you for allowing us to represent our bid today for the Rutherford County Clinics. We certainly are honored to be a part of the solution. We have with us today Dr. Wright Pinson, who is our Deputy CEO and Chief Health System Officer. He is President of the Vanderbilt Health System and Chairman of the Board for Vanderbilt Health Affiliated Network. We have Pam Jones, who is a Senior Clinical Leader for our Employer Health Clinics, myself, of course, and Lori Cruz, who's Director of Advanced Practice Faculty Clinics. So everybody has a small role to play today in giving some detail around the proposal that you all hopefully have seen, and we'll be happy to also address additional questions. I don't have a great deal of detail to cover for you. I'm going to leave that to the clinical experts. So first I'm going to invite up Dr. Pinson to come and speak to the group on our excitement around this opportunity. Thank you.
Hello, Mr. Pinson. How are you? Welcome. Yes, sir. Good seeing you again.
Ladies and gentlemen, we're happy to be here this afternoon. We're here for a very specific reason. We want to express our eagerness, our enthusiasm, and our commitment to providing a great solution for you, for your employer-based clinics. We are very experienced at this process. We know how to manage providers in this sort of a setting. We run a number of employer-based clinics in the metropolitan area. We have been very good partners with Cigna in running some of those clinics successfully. We've had excellent outcomes in a number of these clinics. Probably the largest and best well known is the Metro Nashville Public Schools clinics. We have worked with them for the past 11 years. More recently, we have begun the process of developing employer-based bundles, and so we are attempting to continue to be fairly innovative in this area. We have been able to demonstrate that we can be an excellent partner to employers in this role. We're eager to run this efficiently and as lean as possible. We want to, at the same time, meet whatever needs you tell us that you would like us to meet. And so we're happy to enhance our services to whatever level that you would like. The next point I'd like to make is our goal here is to deliver health. Not health care, health. And in an employer-based clinic, what you want is you want your employers to remain healthy. And so this clinic is really intended to be on-site. It's intended to keep people at work. I will tell you, we'll have a backup for those who need it, but the vast majority of the work that we intend to undertake and do undertake in our other employee-based clinics, employer-based clinics, is to keep people healthy. We have had excellent providers. I have practiced as a surgeon at Vanderbilt for 30 years, so I'm a little biased, but I will tell you that it's a very good group of physicians that start at the front line, and you have any level of backup that you need to the very complex. We have a network that these clinics will be integrated into. We have a number of providers that are working here in Rutherford County. In addition, we have the Vanderbilt Health Affiliated Network with a number of other providers. There's a total of about 100 that practice in Rutherford County. We have 15 subspecialties here that we operate. There's family medicine, there's OBGYN, there's walk-in clinics, there's internal medicine, there's pain medicine, there's geriatric medicine. There is a behavioral health clinic. There's children's surgery and clinics that we have just opened. There's an eye institute here. We've got the Vanderbilt Rheumatology Department. We've got a cardiology group that includes interventional as well as general cardiology and peripheral vascular medicine. We have a maternal fetal center here. We have a surgical weight loss clinic here. We have the Vanderbilt Family Medicine Group, otolaryngology, and then we have retail clinics at Walgreens, at Kroger's Little Clinics, American Family Care, as well as the Vanderbilt Children's After Hours. So that would be sort of the second line that would be available after the employer-based clinics. In addition, the Vanderbilt Health Affiliated Network has over 60 hospitals in it, one of which is located here in Murfreesboro, but obviously we have a hospital that is up in Lebanon, and we have another hospital that is west of here in Williamson County. All of those are in the Vanderbilt Health Affiliated Network. Altogether, there's more than 60 across the state, so wherever your employees are, they can access hospital services as needed. And supporting those hospitals all across the state are between 6,000 and 7,000 physicians. So behind this employer-based clinic and integrated through an electronic medical record that carries are all of these locations here in Rutherford County, as well as all of these locations that I've told you about across the state. I think the next point that I would like to make is that we don't expect many of these employees to require hospitalization, but if they do, we are certainly willing to take care of those patients, and we do take care of patients from here on a regular basis. We've had about 3,800 discharges from our hospital in Nashville for citizens who live here in Rutherford County. We also, in the past year, had 36,000 outpatient visits here. You might be surprised to find out I'm particularly concerned because I have over 2,000 employees that live in Rutherford County. So I have every reason to make certain that the services here are absolutely superb in these employer-based clinics, but in the backup that's above that. And we have invested recently, as you know, and we have plans for further investment of assets and services in Rutherford County. I'm going to stop and let others tell you more details about the work in these clinics, but the main message that I wanted to deliver to you is that we are eager, we are enthusiastic, we are committed, and I am personally here to tell you that I will make certain that you are happy with the services that we get. Whether it's in the 3 locations that you have now, or whether you want it in a new location, we're happy to reconfigure this in any way, shape, or form that you would like. Thank you.
Thank you, Dr. Pinson.
Good afternoon. I'm Pam Jones, and I'm a nurse leader. I'm responsible for our current employer health clinics. And just on a personal note, really quickly, let me tell you that my mother-in-law taught for this county for over 35 years, including 24 at Walter Hill School. So when I worked on this proposal, it was very near and dear to my heart to think about the care that your employees and your citizens here need. So I'm going to give you a little more detail about our employer health clinics. We have been in a very active partnership with Metro Nashville Public Schools, so I'm going to use that as sort of our exemplar today to talk through, because there's a lot of similarities with what happens there. An incredible partnership, and part of what I want you to take away from today is that we don't come in with a cookie cutter of what we think you need. We work with you and your data and the needs of your employees to design the future system for you. And that is an important distinction, because the reality is these programs need to be refined and built to improve the health and to decrease your cost over time for these individuals. And part of this RFP process is to begin to discover what organization can really help you think about that differently and think about that progressively. And that's what we've had quite a bit of experience doing. The RFP currently includes the bulk of the staffing that you have today in those, but we did add one important component, and that is the addition of a psychiatric nurse practitioner integrated into that primary care team. One of the things that we know both from the literature and from our work at MNPS is you cannot just treat the body, you have to treat the mind as well. And certainly when you think about the stress level of some of your employees, those components come into play. So we believe that behavioral health is an integrated model where that's a need just like anything else that those individuals have. And as you know, access to behavioral health services are extremely difficult for people. We already have one psychiatric practice in this community, and we know it's gotten busy very quickly. There's not enough individuals in the behavioral health arena. So that was a very important addition into this model, and we feel really strongly about that. Another piece that we believe we'll bring to the table is really enhanced metrics and measurement, not just about performance standards like wait times and satisfaction, those are all important, but also working in concert with Cigna to really understand what is the chronicity of your employees, what chronic health problems do they have, how do we build systems that address those, improve the health of those individuals, hypertension, for example, how do we really start to tackle that, diabetes, those types of things, working in partnership and getting those individuals into care. Another piece that I'm going to talk just a little bit, because I don't want to run out of time, about some of the results out of our current MNPS system. And as Dr. Pinson said, we've been at this with them for about 11 years at this point and have learned a lot over the years. Very active partnership with them. We have proven results with them. There was a RAND analysis, and this was included in your RFP, that looked at over 7 years of data with teachers that use those clinics versus standard primary community care, what those outcomes were. And there were lower inpatient admissions, lower annual health care costs, and lower annual absent work hours. So those are proven statistically significant results out of that analysis. We believe we can replicate that here, just like we've done in partnership with MNTS. If you think about your escalating healthcare costs, some of the results we've had out of there over 10 years is they went on average from an annual increase of 6.6% to an annual increase of average of 3.8 in 2018, and the last fiscal year was a 0.6% increase in their annual healthcare spend. If you talk to MNPS, they will tell you one of the reasons for that is because of the work we've done together in partnership. So a couple more results. 50% of the teachers in Metro Nashville use those clinics as their clinics, and 43% use them as their true primary care home. One of the things you want to do is build a system that's not just episodic in nature, but brings people in as their primary care home so you can engage them in a partnership to improve their health. And again, we know that is a key to success and believe we can do that. Excellent performance measures out of the Cigna data, patient satisfaction of 97%, which is extremely high. And again, an ongoing focus on that clinical quality, getting those measures, understanding what does that mean in terms of the health of your employees. We do have a strategic advantage, as Dr. Pinson said, of being able to recruit and retain extremely qualified physicians and nurse practitioners. We have the highest standards for those qualifications for those individuals. The School of Nursing has one of the largest training programs in the country for nurse practitioners and advanced practice nurses, and our retention rate has been exceptional. In 2017, we had a 100% retention rate for all of our nurse practitioners, and in 2018, it was a 97% retention rate, because we really do understand how to create an environment where they feel satisfied and they feel like they are working as your partner to improve your health. Very structured onboarding processes. I've mentioned the quality measures. You've got an example in your packet just of a little snapshot of what those measures might look like. This is a Cigna tool. We will have multiple others, but this just gives you a little snapshot. The last page, I just want to hit on a couple of things that we believe after working on the RFP. I've already mentioned the integrated behavioral health. I believe there's an opportunity to enhance care coordination. That's one of the things that we've done to decrease costs at MMPS, is making sure that the care coordinator in the clinic is managing those referrals to specialists, getting them in a timely way, getting them to the right level of care, following patients post-discharge from the hospital, making sure they're integrated back into the community with the resources they need. So again, if you think about this comprehensively, it's more than just when somebody walks into the clinic for a visit. It's about really looking at the whole continuum of care for those individuals and helping manage that. We want to do an extensive review of the operating hours and locations, as with our expertise in partnership with you and better understanding the needs of the users, to really understand, are they right? Do we need more in some areas? Do we need less in some areas? We think there might be some efficiencies that could be gained that then could be recirculated into additional services. We're very experienced in building and designing systems as well. So I know part of the discussion has been around thinking about a future model that might be different. We've had the experience of helping MNPS build their comprehensive center they've got, and we're in the process of doing that again for their second site with that. A deep dive into sort of an analysis of your current pharmacy program and the pharmacy spending, and understanding, is that the best use of your dollars for those pharmacy dollars today, and trying to interpret whether those are is the right formulary, and do some changes need to be made there. And then again, as Dr. Pinson said, we have the ability to tap into a broader system, and we'll have an integrated medical record where you can have seamless communication not only with the patients, but with the specialist and others. Very high level of the financial model here, and there's additional detail on the spreadsheet that looks like this. The other's pretty small. But the implementation costs, and these are an estimate because we haven't done a real detailed analysis of each clinic and what every piece of equipment is, for example. But for that, an implementation of the electronic health record, one-time cost of around $240, and then the first year primary care cost of $2.8 million, which includes that Psych NP that I mentioned. We had put into the proposal potentially an occupational health nurse, but took that out because our understanding was that was something that wasn't at this point in time needed. So that brings it to a total of a little over $3 million. And that is the end of the formal presentation, but we wanted to open it up for questions and see what other information we could provide.
Okay. It's now open for questions for Ms. Jones. Well, somebody was going to ask the same question as they did last time, so Mary, go ahead.
Okay, I was giving everybody a chance. You've kind of touched base on that y'all are working with Metro schools. Okay. What other government entities and/or utilities do y'all work with? And the reason why I ask that is I don't want to step on anybody's toes, but our group has teachers and truck drivers, bush hoggers, secretaries, all of that. So when you're dealing with the teachers, it's a little different when you throw all the rest of the guys in, if you will. I work at the highway department, so that's why I'm asking this.
Sure.
So are there other utilities or governments that you work with that have a little more than just teachers, where there's a span of education, time, job description
Yes.
that you work with?
So let me clarify a little bit, because for Metro Nashville, we work with both the teachers and all the other non-certificated employees. So we have bus drivers, we have cafeteria workers, we have all kinds of individuals that we work with there. In addition, at the Gaylord Opryland site, we provide services there as well, and we, the people who drive the boat, we've got all kinds of employees, kitchen, food service workers. So we have a pretty deep experience, because you're right, those social determinants of health and with different employees are different, and you have to have different strategies. And doing DOT physicals, for example, where you've got to be sure that people are competent to drive the buses, we have a lot of experience doing that. Does that help? Okay.
And another question, and I've got several, so y'all jump in if you need to. I'm not sure if it was you or the other gentleman speaking to the doctors and referring. You're going to be sitting in our clinics, if you will, and you're needing to send, and I'll use me as an example. If I need to be referred out of the clinic, it can't be handled. Are you willing, you as I say, Vanderbilt presentation here, willing to send me outside of your Vanderbilt doctors? I mean, we've got MMC, we've got St. Thomas, we've got HCA in Smyrna, Stonecrest, thank you. So are you able to and willing to, as long as they're in our Cigna network, for convenience of our employees, send to that without sending them to, and I realize you have clinics here in the children's after hours and stuff like that. Can you touch on that, please?
Absolutely, and I'll let Dr. Pinson add too, but we do that today in our MNPS clinics as well. And the role is to work as a patient and consumer advocate to try to help you get into the right level of care that's right for you, that gives you the right provider that you need. Because what we know is when you're a consumer and you're trying to navigate our health system, you don't even know the right questions to ask, you don't know who to call, particularly if there's an unusual situation. And these care coordinators become very adept at understanding how to get you in when you need to be seen with the right person. I don't know if you want to add anything to that or not.
And just for a clarification, I don't like to drive, and I sure would hate to have to drive to Nashville to go to the doctor.
Absolutely. We understand that concept well. But, again, it's about partnership, and we would not want to work with you to design a system that didn't make your employees happy and healthy. So that's really what it's about. It's not about just assuring a stream of referrals.
As far as referrals, like Vanderbilt Heart here, that's part of y'all's system, y'all's network. So instead of having to go to a Nashville doctor, they have that available here, right?
Part of the reason that I emphasize that we have 100 affiliated providers here and talked about all of the assets that were here is that I presumed that most people do not want to go to Nashville. And as I tried to explain, I think the vast majority of the work here will stay local. And as I mentioned, the hospital that's here in Murfreesboro is in the network. Other hospitals around here are in the network. And my expectation is the next level of referral, if it's needed out of the clinic, will be here locally, some of which might be Vanderbilt providers, but the vast majority, in fact, are not. And we have no limitation whatsoever from our point of view, working with the Murfreesboro Medical Clinic doctors, working with the St. Thomas doctors, working with other independent doctors. There will be no limitation on our part.
Amber, and then Lisa.
Data perspective, I know you all seem pretty data driven, and you said as you're assessing that data, you're building out different programs, you're partnering with Cigna. Who's actually assessing that once, like, if this commitment is made? Like, what level of person is actually?
Well, so we have our clinicians involved, and so we would work with Cigna, because Cigna has a lot of expertise as well at looking at trends and quality data and those kind of things. So we would work with Cigna, and we're very experienced at doing that. There's a group of us that we call our operational group, and like I'm a doctorally prepared nurse. Lori, who's the director, is a family nurse practitioner herself. We have a physician that we work with. So you take clinical experts who are also operational experts and look at that data in partnership with whoever the right person from this organization is. And what we bring is the clinical expertise to help you understand, okay, if I have a problem with diabetes management and getting my employees to the right level of blood sugar, what are the clinical alternatives that we can put in place to help do that? That's where we bring the clinical expertise to partner with you. Does that help? Okay.
Lisa?
I just wanted some information with your experience with Metro schools. If you could kind of touch on how they started and where they are today, because I think you mentioned that they've built a dedicated facility just for their people. You know where we are.
Yes. So you're on the same journey that they were on. So I actually participated initially with MNPS. They actually approached the School of Nursing first to say, you've got people here who understand chronic disease management and population health. Help us design the system. So the School of Nursing was a consultant to them from the very beginning. And it started in trailers near the schools. So their philosophy was have a site within 15 minutes of each school. And Nashville's pretty spread out like you guys are. So that means there are things all around the county. So it started in trailers, in portable classrooms that were backfitted as clinics. And most of the sites still have that. But what they did is over the years, they had so many documented savings from their self-insurance trust that they paid for the new facility, which is a comprehensive health center with a huge fitness center, on-site pharmacy, on-site PT, on-site chiropractor, the full clinic with 4 family nurse practitioners and 2 psych nurse practitioners a day. And did I forget anything? Chiropractor, did I say that? And care coordination function out of that central location. That was all paid for by the savings, and then they shut down one of the sites' portable classrooms. They're in the process right now of designing the second one of those to replace the second busiest site is going to be replaced with another comprehensive health center. And that comprehensive approach has been really impressive because people actually use the fitness center. They are really engaging in health promotion activities. Did that answer the trajectory there? But this all happened over a number of years with close analysis of the data and understanding how to really move things forward. And a very, very progressive individual we've worked with there at MNPS.
Questions? Mary?
You guys read each other's minds up here?
Okay, just one of the ones that I want to touch on, you were talking about your portals and your own lines and being able to do all of that. How easy is that? What y'all have to offer for? I'm saying it for myself. I have a smartphone. Is it easy to dumb down for me? That it is being, that I can use it without the help of my 3-year-old grandson.
Yeah, it's pretty easy. It's got a nice interface to be able to go in and see a summary of your visits, see your lab results, be able to schedule appointments online for many areas, being able to communicate with your physician or nurse practitioner, and it can be done very easily on a regular computer. It's also got a good smartphone interface. I can use it really easily, and my 20-year-old son tells me I'm not very tech savvy, but I'm more than he thinks I am, but still. It's a good system, and it's been designed to be very customer facing, so it really has been refined and defined to be something that our customers want and use. And we encourage people to sign up for My Health at Vanderbilt because it really does allow for a level of communication and involvement in your own care that you don't want to have to just call somebody to figure everything out.
Right. And another thing, you've got the property, I noticed out there that you purchased in Blackman a couple of years ago, not setting anything definitely in concrete, but do you have an estimated guesstimation of when you would like to see a facility up and going in that area? Because it is a booming area.
So we would like to get started on that as soon as we possibly can. I think the amount of work that we have here and the amount of work that we could predict that we might get here will certainly dictate how much we can accelerate that plan. I can't give you a specific date, but obviously we don't want to just sit and do nothing for very long.
Commissioner.
I do want to mention around this My Health at Vanderbilt, there are over 500,000 people that use My Health at Vanderbilt. We've signed up 85,000 of them since July. The satisfaction rate, there's a 5-box, very satisfied, 87% report that they are very satisfied. Some of the things that you can do on that, which are terrific, is you can book your appointments online. You don't have to get on the telephone and call anybody. You can book your appointment online. Another thing you can do if you want to be a walk-in patient is you can just call up and say, I want to come, and they will tell you and say, well, be here in 15 minutes or be here in 30 minutes. Or they will tell you another way to do it is you say you want to come, and they'll tell you how many minutes. So being able to use that online portal, the patient portal, turns out to be not only a great way to access your medical record, but a great way to access care to begin with. And there's a lot of educational materials that are in that portal, so it turns out to be a great way to engage patients, or in this case, employee patients. It turns out to be a great way to engage patients.
Okay, thank you. And I don't know that this will be the last one, but here's another one. Did I miss it in your presentation? Is Rutherford County going to have a dedicated person from your group, and I'm saying not just the ones here, that is dedicated to Rutherford County's account, that if I have a problem and call Ed, he can call, I'm just saying you because, is there somebody that's going to run our account? And we have these meetings every month, so I would anticipate they'd like to be here every month in case there's questions, and we'll want to do reports and stuff. And I may have missed it, and I apologize.
Well, the detailed staffing, our model is this. We embed an experienced leader in the site, and there's an FTE in this to do that. That typically is an experienced practitioner leader, so it's most often a nurse practitioner who has administrative experience. And that person is not expected to see a panel of patients. Their whole job is creating an excellent program there and working in partnership. Then in addition to that, part of Lori Cruz, who's here, who's a very experienced leader in this realm, is allocated to your committee, to this account. Part of my time is allocated to this, part of Troy's time. So you've got an on-site person with I don't want to tell you how many years of experience around them to help support them, and we will be very selective about who that individual is because they are a key component of creating a successful clinic system for you.
Commissioner.
That actually kind of led into one of my questions. I was comparing the staffing between the two proposals that we're looking at, and you've got 3 positions that I'd like for you to talk a little bit more about that are not in the other one. And one of them is that part-time senior leader. Is that the one you were just talking about, where it's like a 10%?
Yeah, that's Lori Cruz. We assume that she will spend a lot of time here, so there's a part of her time that's allocated to you.
And then talk a little bit about the LPN and then the psych nurse again. The psych nurse practitioner. I'm very interested in how that's going to be utilized.
Okay, so when I looked at your current staffing pattern, it is a predominantly medical assistant staffing pattern. And in our experience, that is not the most efficient model, because there are another number of things by state licensure laws that medical assistants cannot do. So injections and part of the assessments for intake assessments, LPNs are really the people who need to be doing that, working with prescription refills, those types of things under protocols. So I specifically changed your staffing mix to meet what the state requirements are for what those individuals can do. So that's the one difference you'll see. The MA count went down and the LPN count went up. We believe that brings a higher level of competency and flexibility into the clinics. The psych nurse practitioner does 2 things. They actually can see patients and do either psychotherapy or medication management. A lot of what they do is medication management for behavioral health meds. And if you look at your medication spend, my guess is you have a lot of spend in that realm. And you want to be sure people are on the right meds for them and that they're effective. So embedding that in there really helps and gives those people access, particularly if they need access quickly into behavioral health services. It can take a long time to get in to see somebody. So they do that, and then they also work in partnership with the primary care providers are there, so they give the primary care provider advice about how to manage things that don't actually have to be seen by the psych NP. Does that make sense?
Do you have any kind of a telemedicine piece to this, and do you have mobile health units?
We have a variety of telemedicine things that we could create for this. We're doing it with all kinds of things. We're experimenting right now with teledermatology, for example, at MNPS. The technology exists. We have a very robust department at Vanderbilt to help us design those systems. So what we would do is figure out what makes sense for you. If you wanted to have telehealth visits available to scale it to other schools that were more geographically distant from the clinics, many of those visits could be done via telehealth with a pretty simple hookup. So absolutely we can do that.
But that's not currently in this pricing model?
It won't cost much more than what there's there today.
So along with a lot of other sort of digital front door services, we have focused on telehealth a good bit over the past 3 or 4 years. We have increased the number of telehealth visits every year. We're up to almost 100,000 telehealth visits in 70 different specialties. One example is we are being asked to produce the plan of how we're going to deal with the coronavirus issue. And I have just told people I want patients to be able to be evaluated by televisits rather than making them come in. And once people are determined to potentially have it, we'll bring them in to be tested. As long as they're stable, we'll put them back at home, and we will follow them with telehealth visits until such time as they appear to be sick enough that they need to come to the hospital. But that's just an example. That's going to be up by the end of the week. So you tell me what you want in your clinic, we'll deliver it.
Can either one of you talk a little bit more about the $240,000 implementation fee, the $200,000 for the Epic, and then the $40,000 for the clinic equipment space?
Yeah, we didn't have a lot of specific information to estimate exactly what equipment replacement might be required. So a typical clinic, we took about half of what it would cost to outfit the same square foot in a typical clinic and came up with $40,000 for replacement capital. You might not spend any of that. I mean, if we go into these clinics and everything looks great, you might not spend any of that. The infrastructure cost for our electronic health record generally relates to running cable. We have to have a very secure vehicle to do that on. That's fairly expensive. Then the hardware that is associated with that. And then there's some just startup fees for getting it all built out. You have to build it out very specifically for each clinic. So that's an estimate. Those costs might be lower. We tried to project the highest we thought, just to be sure you had a worst case scenario.
Sonia? No, I didn't, sorry, didn't see you. I'll get you next.
So in your presentation, you talked about the clinic, the new clinic that you have, the pediatric at the Gateway, and then we've also discussed the land that you're hoping to build on in a future time. Are there any possibilities that the county could have dedicated sites within each of these facilities at some later time if we so chose?
When I said earlier, I know that you have 3 locations now, and we're happy to reconfigure that in whatever way. That's what I meant. And so we may build a new building to put these clinics in. It just depends on what you stipulate is where you want it. Some employers want everything coalesced into one location. Other employers want you to have a lot of different locations. I think you tell us what you want, and we will comply with your wishes.
Commissioner?
I just want to follow up on what Commissioner Allen asked on the implementation process. I see in years 1 through 5, you're only going to budget $3,000 for technology over a 5-year period of time. It sounds like one incident could blow your budget for the entire year.
The bulk of that technology on the startup, so new equipment, is in the $200,000 that you see in the implementation costs. If you look under technology, Epic install, the bulk of the hardware and those sorts of things are in that expense. So the assumption is in the first few years you're going to have all new equipment, so there's not going to be a high risk. This was an estimate based on our current experience at our other employer health sites. We have CWS's clinical workstations that are actually on a lease, so you don't actually replace those very often. It hits another line item, so that's essentially the assumption was the bulk of that expense would be in the $200,000.
So all of that's included internet activity and software upgrades from year to year. All of that's included. I don't get the $3,000, but you may be right on, and I may be overlooking something, but you're planning on spending $15,000 over a 5-year period of time in the area of technology.
Well, there would be other, we've backfit our original, to be honest, we backfit our original financial model into your spreadsheet here. So there would be some other things that would be captured in other line items. But the bulk of what I believe we thought we'd spend was in that startup costs. And I'm looking to see where other things might be hitting. Fees and licenses on I'm not sure what other lines those would hit, but you could be right, but the way we built it was for the bulk of those expenses to be up front.
Other questions? Sonia?
Based on that last comment, if I heard you right, when you were explaining it earlier about the startup, the implementation, is that we might not need all of that. If we don't need all of that, will we still be billed the same amount that will be based on what our needs actually are, not the actual cost?
It'd be a pass-through of the actual cost. That's just to give you a ballpark. That's how we do that.
Other questions? Going once. Okay. Well, thank you very much, Doctor and team. We certainly appreciate your presentation. This committee will take this under advisement after you all exit, and we'll start our deliberation. But thank you so much. Very well done. Doctor, I saw Nathan Green, your government relations person at the Capitol this morning. He said, tell you hello. Y'all have a safe trip back. They're not leaving? I don't think so. Are they leaving? St. Thomas did? Okay, I thought they all left. Okay, so they're all back there waiting. So now we begin. Commissioner.
Follow up on these two spreadsheets. It appears that Vanderbilt included, or we've included in Vanderbilt's proposal, the $240,000 implementation, but we haven't included the $84,000 in the St. Thomas presentation. Is there a reason for that?
The $84,000 is included in their management fee. So if you look at, I had the same question. If you look at the first asterisk, implementation costs are covered in the management fee in year one. So it is included in the 2.921 number that they showed.
So that 2.9 is the actual for the first year? And,
correct.
And then the 3.
Yeah, they did not include it in theirs, but the other did.
The 3.
But we put it both in our spreadsheet.
Yeah. So first year would be roughly 3.047 for Vanderbilt and 2.921 for St. Thomas.
And if you look at the bottom line for Vanderbilt, over the 5-year period of time, it's almost 15.4 mil, and the bottom line for St. Thomas is 14.9.
And maybe flipped. Your numbers are right, but flipped. So if St. Thomas is 15.4 and Vanderbilt is 14, right at 15 million. Yep.
That's right. So although it appears that from the initial spreadsheet that you supplied us with, that Vanderbilt is the highest.
Year one, yep.
But if you look at the bottom line over a 5-year period of time, Vanderbilt is the lowest.
But the 14.9 doesn't include the implementation, so you got to add that back in there, and then they're literally $200,000 difference over 5 years. So you're true still, but
yeah.
It is about $200,000 difference.
What we found interesting was they were so close in total cost over a 5-year span.
And then they're both about 1.3 below what you're paying today.
And the bus, you got to think, in St. Thomas, the $150,000, so that adds another cost savings that's not included in Vanderbilt's. But if you didn't use the bus, then you've got another $150,000 savings, right?
But Vanderbilt has a psych nurse in theirs.
Yep. And I will say, just the one other kind of clarification, Vanderbilt, the costs that you're looking at, we're out at 15 million, does not include whatever it might cost to add on and or be part of that 82 acres that they discussed, right? So he was very clear that it's an option. Right. We don't know what that option is.
But the St. Thomas isn't included either, but that would be, like they said, another $60,000 for the New Salem if we decide to do that.
So what, and I'm focusing on money, if I will, but what I kept hearing Vanderbilt would say, we'll give you anything you want, but I'm assuming that anything you want is going to be an additional cost. And the St. Thomas presentation, to me, sounded like it's a package, and they're pretty set on that proposal, correct?
Correct.
Except for the 60,000.
Right, yes, thank you.
Lisa?
I mean, that's what I got to, is that if you're looking just at dollars, you've got to take that 156 off of the St. Thomas bottom line to be
apples to apples. Yeah.
Are you talking about the mobile health unit?
Yeah, the mobile health unit, because Vanderbilt doesn't have it, but it is included in St. Thomas's costs. Yeah, and then, like you said, Vanderbilt's got the nurse, the psych nurse. Yeah. But I think when you get down to it, the numbers are very, to me, the numbers are so close. But you can't add the 60,000 because Vanderbilt is saying, we're using your facilities. I'm sure if we found another place, just like St. Thomas, they've got that place available, but we may choose to go somewhere else and rent space that I think St. Thomas would be willing to move wherever we tell them to move.
Right.
I feel like there's this.
That when Commissioner Allen asked her question, I was getting ready to ask that, but I wanted to follow up with that. They budgeted $3,000 a year for technology. We spend that way over just with what we have within the county, upgrading our systems every year. It's a drop in the bucket. I'm confused how they can run and update their systems for $3,000 a year. And what would happen if they couldn't?
Yeah, I mean, it's a fair question. It would be a pass-through cost, to your point, and I think they believe that the initial $200,000 would get you a system that is good enough for at least 5 years. But I'm with you. I have seen things break after 2 or 3.
Right. I think that they're saying there's $15,000 there, probably good for 3+ years, and then it may be they spend the whole 15 in 1 year. But if it was more, it would be a pass-through cost.
All right, Mary.
Okay, just a comment on that, but then I have some questions as to implementation and changing and all that. So I'll either, if I start on it and it needs to be held, just tell me, hold on, that may be next month or whatever. But in looking at this and like Commissioner Phillips said, St. Thomas comes across as more of a packaged deal that already has, whether we use it or not, additional bricks and mortar on built, whereas Vanderbilt says we can. Well, in this county, it takes a long time to build anything and to get it approved to be built, just to be honest. So I do like the package deal on them, and I realize there's a psych nurse with Vanderbilt, and we got a mobile bus with St. Thomas. I know everybody could go to the psych nurse, but I foresee that everybody is more apt to use it. I would probably test it on me. But I could see more utilization of the bus than the nurse. Because more than likely, and I hate saying this stuff because I sure don't want to belittle anybody, but if you needed a psych nurse or that, you may have already been seeing someone yourself. So, yes, it leaves it out there for somebody that may not need it, but if you have this mobile bus that can come around and roll up on, out at the highway department or roll up at a school that can offer the blood draws or the flu stuff, things like that would save time for my guys or anybody else taking 2 hours off to run across over here, get that took care of, and come back. I honestly, in my personal opinion, and the ones that I work with and deal with, I see us using the mobile bus more than having that additional psych nurse person. That's just personally of what and who I work with and deal with around.
And you're still, comparing what you're paying today is about $3.15 million. If you wanted to ask, as we start implementation, if that's something we wanted to talk to whoever we go with about, we may be able to have the mobile bus and that and still be in line with what we're paying today.
Okay, so that leads into, and tell me if it's not the time if we actually need to decide. I got questions like, how is our medical information coming from Premise Health to the new person? Are they being able to share that information, or is Premise Health going to say, no, this is our information, although it belongs to the employee because it's theirs? Are they going to hold on to it, or how are we implementing sharing that information to the new provider? How are we going to make these changes in these clinics? Because just like when you have, when Greg come in, he took an inventory, you know, and so I would anticipate that we would want to take an inventory as one walks out and one walks in. So how are we going to handle that in our clinics and personnel? And tell them, just go, okay, personnel, how are we going to, who pays them? I know they're not a county employee in that they get our benefits, but did they sign up for non-competes that they got to leave with premise, or could the new people, and I understand at St. Thomas, she said, you know, we would be willing to go in, so is that possible? So one is, how's our medical information going to get, and is it going to get current over to the new one? How are we going to do an implementation and be able to wrap our minds around what we've got on the ground physically in a box in a drawer? And then what are we doing with personnel?
I'll maybe give the short answer, and then you can give a longer answer, or you will give the long answer. I would say the short answer, because we have some similar questions, the short answer is we need to decide on who the vendor's going to be. And then we have a 6-month implementation. So, I mean, to your point is we know this is, once we make a vote and a decision, really the heavy lifting starts, because there's going to be a whole implementation process where we have to work with whoever that vendor is. But then, so that's true. We haven't gotten there yet. We have to September to do it. That's why we're really pushing to get the decision today, to give us the 6 months to do a lot of work. But to answer the other questions is, we have all the same questions. You have a wellness program we have to think through. Biometric screenings happen during the same time. That type of things we're talking through. The staffing is something we are talking about. Both of the vendors today are open to suggestions there. I forgot one of your other questions.
The inventory, there are inventory lists already done.
The data, I mean, if we're being fully transparent, we lost all the previous data with the move to Epic. So we only have 1 year of data out there today, you know, because with that transition within premise, we lost the previous data. So questions there, but it's not like we have 8 years worth of data that we're going to be transferring over. But
okay, so basically, we need to decide who today, and possibly allow y'all, whoever that y'all would be, to come back next month with, okay, we need the insurance committee to decide on how are we going to do this, or based on legal stuff and everything, we have to do this, this, this. So none of that really comes into play as to who, because that is Rutherford County general, and I say general, the whole, just Rutherford County, that has to make those decisions, and we're not tied to them holding our information hostage. Because when I started here a long time ago, when we swapped from one medical insurance to the other, they held us hostage basically on our information, and I didn't like it, and I still don't. So that's one of the first things that I want to make sure that the information, because I believe it's ours, our employee and our employer's information, because you're doing the service for us. So basically, you're needing just a decision, and we still have time to decide the other stuff. Okay.
Commissioner.
I have 3 questions and 2 comments. Just want to brace you for that. Okay, so you'd mentioned Epic, that we've gone to Epic. So I guess that was one of the questions I had about the $200,000 expense. Is that a real expense? Because, I mean, we already have electronic medical records.
I had some of the same questions. I mean, that's what I know we've conservatively put that in there, and if it comes in less, it comes in less, but I had the same, we probably should have asked, but it was in the RFP that you use Epic today, so I think that is a cost for Vanderbilt to put in their software and hardware for Epic.
And he mentioned certain cables. The cables that are in there today may not be the cables that they have to use for their So that is something we would follow up on. But as they said, if we don't have to pay it, then that cost is not going to be charged.
Yeah, we're going to need, I mean, if we
Yeah, I
decide
mean,
to go with them, we're going to need an IT person to kind of shepherd that, because it would
Absolutely.
be real easy to hoodoo us and
Right.
tell us, I
Absolutely.
need this MacDaddy cable that's not there, when maybe the cable that's there can do the job, because obviously we have current legal obligations to keep that information secure and to transmit it, so there's part of me that says it may not be the latest and greatest, but it might do the trick.
Right.
So
Agreed.
that. I do have a follow-up question on Mary's, and that is, what does the transition period look like from the employee standpoint? If I'm receiving care and you're managing a chronic condition for me, what does that look like for the employee during that transition period? And so I guess part of that too is, let's say we make the decision, it doesn't start till September 1, but there's that transition period. They're maybe going to hand the keys off September 1, but there's a whole lot of work that has to happen between them. So do they start working before September 1? Do they start getting paid that management fee before September 1? And from the employee standpoint, what does that look and feel like? So any idea?
It's just like if we take any new product, whether it be medical dental vision or a disability, there's an implementation period that we begin working on, and that's part of their package usually. Typically in our department, I'm the one that works on the implementation, is why I say that. During the course of that implementation period, and whatever we decide with the vendor how long it's going to take, our team works with whoever's chosen to ensure that September 1, we have everything in place. We underwent a conversion of clinics back in 2012 from who we have currently and who we had previously. What we did then is we modified their schedule, and we actually had to shut down 2 of the clinics, and at the time we actually had 4 clinics open. We had to shut down 2 and do a modification over to 1 clinic to service those appointments while we went in, because Mary left, but we actually go in with both partners, the incumbent who we have now and who we're getting, to inventory what is there. We usually are there present, so we make sure that anything that gets taken out of that clinic doesn't belong to, well, it's going to belong to Rutherford County, and that gives the vendor that's coming in the opportunity to see what's needed too, to see what they need to bring in. They may prefer to have a certain, I can't think of anything offhand, but something different than what is there. So, and that's something that we work with them on too when we start the implementation. So that's something that we really haven't discussed a lot. It would depend on who gets the contract, and we would sit down with them. That would be the first step, is start with the implementation and decide how are we going to do the conversion.
And I should know the answer to this, so again, apologize if I don't. Do we triage our OJI injuries at these clinics? Is that something we should do? Why?
Well, you've got employees' money in the Employee Benefits Trust Fund, and if you're doing occupational, you're mixing occupational money with the Employee Trust Fund money, which there's some contribution by the employees. Where it's not occupational, that would be all on the county.
Is that the reason that you think Vanderbilt took the occupational nurse out of their proposal? I mean,
Premise doesn't do it today, so they were trying to keep it apples. They would be open to doing that, but they were trying to keep it apples to apples.
that's actually what made me think, did it need to be in? That was what made me think.
Right.
When they said they were taking it out, it made me wonder, how do we do that now? So.
You can do it. It's a little complicated because it's more on a fee basis. It's not, because you're taking up the services of a nurse practitioner or a doctor or something like that that's being paid by the Employee Trust Fund. So it's a lot cleaner if you don't, but if you decide to, then there's other ways to, charge for that service. Back into the trust fund.
And when I say it's not a big deal to me. They said they took it out, it made me wonder.
Yeah, not to interrupt you, but there's a few things. It's a great question, and it's something that Sonia and I have been working on and talking about, other things that we can do outside of what we're doing now. But today, I didn't want to confuse people with all of these things floating around to where we can get closer to apples, and then we'll come back to you If we decide to pick a location outside of the 3 that we have now, we'll come back and, with the committee, even, there's several things that we could tie down, but, we just tried to keep it as simple today as we possibly could.
May I say something? One of the things that we looked at a while back, this has been a couple of years ago, we were looking at that theory of having OJI, even FMLAs. The thing about it is when we discussed it with the attorneys, there was some issues with the liability that it may look like if you're treating the OJI and the FMLA and maybe they return an employee to work and the employee doesn't think they need to, then they're saying, well, the county's making me return. And so from a liability perspective, it's better to keep those type services separate from what our employees are using from like a healthcare, like a walk-in clinic type thing, is keeping the occupational health and anything that's related to them taking leave and those type things. So the idea was never to have the clinics to be like a primary care physician, but more of an acute care type things. And then they do assist with some chronic conditions, but just kind of felt like the attorneys just kind of felt like that it would be better to keep those separate for the county so that we wouldn't be putting somebody back to work who felt like they weren't ready to go back. So if we're using a panel physician that's not under our umbrella, it's a little bit cleaner kind of thing.
Okay, so the 2 comments were on the bottom line for the sheet that you guys provided. The difference is roughly $125,000, and so $100,000 of that is the psych nurse. So it seems like that is something that we could fold in. And we talk all the time about the mental health issues. I mean, I'm chairman of Health and Ed. We talk about this in building the budget and in the staffing and how desperately that's needed more in our school system. So I can only imagine it's probably the case that it's needed, inside of our employee population. So that probably is something, Ed, that y'all, as you're looking at things you might want to do differently. I'm not saying make it part of this package, but it probably is something we need to give some close consideration to. And then the other thing was I didn't really like the answers that I heard about staying in network. From an employee standpoint or employer standpoint, employee satisfaction is driven a lot by their benefits, their health insurance, all that. If I have somebody at this clinic telling an employee they need to go somewhere else and it's outside the network, I could very easily hear that employee then say, but your person who you hired to manage my care said I need to go somewhere else, so I shouldn't have to pay for that, or I shouldn't have to pay differently for that. So I would really like a commitment from these clinics that they're going to be very diligent about referring in network unless there is absolutely some reason that they don't need to refer in network. I think that needs to be a higher priority than what I felt like it was conveyed from either one of their answers.
And I think they were trying to address more of that, because some of the questions we've all had is making sure they're not directing care to their facility. And I think they were trying to more talk about that as well, so they didn't really answer your question well, because I think that's what was in their head more.
Well, and two, I think with both of them, the way they answered it was, we're going to make sure that they get to the best care, blah, blah, blah. And of course, they're all going to think their network's the best. They should, and that's the nature as you refer inside your own network. Right. But I just know from an employee satisfaction standpoint, because their cost is going to go up if they go somewhere else, and they're going to be very disgruntled with us that we're not going to pay at the same level if they go out of network. So we just need to make sure that they're committed to referring in network as much as possible. And like I said, and we can always find those outliers, those reasons why you wouldn't, but as much as possible.
I think we can make it a requirement, any referral, right up front you tell them, it's in network or out of network. And what I mean by that is if you have somebody there that says, this is who I go, I know it's out of network, but this is my doctor I've had for 20 years, and if they want to go out of network, say, okay, we'll refer you, it's out of network, but we're just letting you know. But I think, and I hope the committee thinks, that one of the requirements is number one on referral is you tell them up front, it is in or it's out if you're doing it. And every referral they should make every effort in every referral to be in network unless a patient says, I don't want to go there.
And then the last thing that I would just want to know is from you all, I mean, you see these all the time. Is there anything specific, knowing our history, is there anything specific that you see that distinguishes one of these from the other, because you've got one who's the hometown local person, local connections, but really who's never done it before. And then you've got, Vanderbilt, which is this massive system, who has a lot of experience at it, but is Vanderbilt. So is there anything about these that stand out to y'all?
Well, I would say what I think is good is that they have two completely different approaches, in my opinion. Vanderbilt seems to be going all in on the clinical piece. Higher level nurse practitioners, I believe they said, less medical assistants, and the psych nurse. So they're saying our clinical model, we believe, will save money, the studies show, and we're going to provide a very high level clinical service.
But we're going to be at the same locations you are today.
But we're going to be at the same locations. I think St. Thomas has said we're going to provide good service, but we're going to give you that expansion opportunity to get out of a portable and have a mobile bus that you've wanted. I think all costs being relatively similar, that's the ultimate question, is which one distinguishes, what's your choice? Is it the maybe a touch higher level nurse practitioner and psych nurse, or is it the mobile bus and the ability to get out of a portable that you may not want to be in 5 years from now?
Because I think it came across, it seemed like St. Thomas, if one of the goals is to try to get off the schools, out of the traffic, a little different facility than Blackman's, portable, St. Thomas is probably 3 years ahead of Vanderbilt from that perspective, because there's still a piece of land that they have to build on. But then you may say quality might be different over here, but that's, as Jake said, I think that's where you are.
And Commissioner Phillips, we think about the dollars too. Vanderbilt has the land. Vanderbilt's probably going to build a building. We don't know, number one, what that rent would be. Number two, if they gave us part of that land, like Metro Nashville Public Schools, they built their own building at their own cost. That was not included in any of these numbers, right? So keep that in mind. That is a complete unknown if we were going to build our own building.
But if they had the plans today, by the time they started permitting and everything else, you're looking at 2 years minimum before they could even occupy, get the C of O on a new building out on Veterans Parkway. I've got Shay, Eric, and Amber.
Thank you. I just wanted to say that at this point, I love the idea of the mobile unit. However, I like the idea of a psychiatric nurse more. I do. Speaking on behalf of teachers, there are some serious mental health issues, and it not just from the teachers, but for their families. And in Rutherford County, there are 2 prescribing psychiatrists for adolescents total, that I know of. There is a 1.5 to 2 months wait to see a psychiatrist for the first time. You have to go out of county to find anybody to get treatment. The idea of us offering our employees a dedicated psychiatric nurse that they could see within days, you have no idea how much time that will save our employees who need it. You have to go out of county, to get your prescriptions modified, to see your psychiatrist once a month or something like this. So, I know a lot of teachers, who are constantly having to take time off work to get their kids or their husbands or themselves to appointments out of county because there literally are not enough practitioners here. This would be huge for the teachers of Rutherford County. And a mobile unit would be fantastic, so I wouldn't have to leave work to get a blood draw, but quite frankly, we could ask people at our clinics to send a nurse into the schools to do a blood draw. You don't need a mobile unit for that. In terms of cost saving and time saving for teachers. So, that's 3,500 employees right there. But the benefit to the county at large, particularly when you're dealing with a mental health crisis, the idea of having somebody you could see quickly, that's something nobody else in this county has right now. Nobody else. So that would be incredibly beneficial, and I'm for Vanderbilt right now for that reason.
And I'm not sure that St. Thomas can't do the same thing, would be you could get your mobile unit and that, possibly.
It's not included in the bid, It would be an addition.
Yeah, I just got an observation. First, that would be something to ask St. Thomas, if they could provide something, if it's that important, that would be very good to ask them. Yeah. Maybe they could work it in, but here's what I wanted to say is, as a financial planner for 24 years and as and working in the health industry that long as well, I'm a numbers guy, and when I look at the numbers, it pretty much is dead even over 5 years. It's dead even. So that's really not a factor because it's plus or minus a percentage or two. So it comes down to the user's experience and customer satisfaction. And I'm one who I live in Rutherford County, and I like doing business with other people who live in Rutherford County. And knowing that St. Thomas is based here, or the people are based here in Rutherford County, that's kind of important to me, that I know that I'm not dealing with people who live in Nashville. And then as far as the mobile health units go, I've seen them in action. I work with several homeless ministries and food distribution ministries, and at no expense to the local community, they make those available. And as I said, I've seen them in action, and they're pretty impressive what they bring. So having those mobile units, I think, is fantastic. So anyway, that's just my observations there.
Amber?
So I'm a little scattered a bit on this because I appreciate Vanderbilt's presentation because it was very comprehensive and they really dived deep into their models. And I'm huge on staffing. Their staffing model seems to really attack some areas that appears to be gaps. So I appreciate that about Vanderbilt. Also, their outside of the staffing, their clinical model too. Like I do appreciate that. But the other piece that and it's just sheer lack of knowledge, is what's the biggest gap and what's the priority for the employees right now that we can really make the best informed decision, or that I can, because right now it's extremely sighted, because I appreciate as well with St. Thomas that they are that hometown feel, and it feels very localized, and that's can only go so far when we're trying to address so many different employees at this time and the different crises that we're running up against. So biggest question is just the gap right now that you all see, because I don't have visibility to that.
Alan?
Do we know the breakdown for our employees that use the clinics versus who use their personal physicians?
Some do both. Some, like if you have a cold or something, you may come to the clinic. If you're diabetic and you've got a doctor you go to, primary care physician you feel more comfortable with, you might go to your normal primary care doctor to deal with your insulin and stuff like that. So
More of your specialty need, you're going to go to your doctor, and that's kind of what I'm thinking. Of course, I like the fact of St. Thomas's, Rutherford's, their package. You kind of know what you're getting. A big thing, kind of Eric mentioned, if you have a bad experience, I'm going to run into the CEO more than likely at Kroger's or Publix or at a ball game or something. I can express my bad experience and not dealing with a nurse practitioner or a doctor. I'm kind of talking to the leadership, which that's important to me. I think it would be important to some of our employees. And I know, speaking from the mail segment, this mobile bus, I know sometimes people don't take time they need to go to the doctor, but I don't have time for that. Well, going directly to our facilities, that might get more of our folks actually getting treatment for some things. So those are some things that I was kind of thinking about. Vanderbilt, the psychiatric aspect of it is very important. It's the variables we're going to have to look at, because the dollars are basically dead even. But I've had family members who've received care from both providers. They both provide, great service. So, but the local aspect is I think that's important.
Jeff?
Thanks. I've learned a lot today. Some of the initial questions that I had have been answered during this process, and I'm thankful to have gone through this. I served on the insurance committee probably before some of you guys were even born, years and years ago, and it operated nothing like this. So anyway, what I'm really trying to say is that we have a committee structure in place, and a lot of times the committee asks the department head for a recommendation. Like in the planning office, we have a lot of folks who do a lot of work, just like in risk management. and they make a recommendation. The Planning Commission doesn't necessarily always follow that recommendation, but I want to ask if this risk management department has a preference before we get into decision-making mode.
Well, to answer your question, I have had the opportunity to visit Metro Nashville Public Schools, the facility they have there. It's a $6.8 million facility. It's very, very nice. I was able to sit down and, Jay and I were able to walk through with them. I've also had the opportunity to visit the St. Thomas facility on New Salem. You've got enough savings here, and I don't want to commit St. Thomas to it, but compared to what you're paying now, you've got enough savings there to put a psych nurse in there if you want to. But with Vanderbilt, you don't have the mobile units, and we're not tied to the mobile units $156,000 a year. It's as we need it or as we decide we want to see, and if they don't work, we can just pull them out and just say they're not working, or we're saturating the market. The other thing that I look at is that, let's say whoever the vendor is, you pick them. You got to have growth, because all of a sudden your utilization takes off or picks up or increases. What are we going to do because you only have so many appointment times in those 3 clinics? That's all you can put in there. Well, to me, the mobile units work out to where, and this is where you have to strike that balance, is if you have people coming in, and you also a nurse, instead of doing the mobile unit, we could say, okay, tell us what you want with a nurse. Let's take 2 nurses, go into schools that would meet the regulations that we need to have, and biometric screening done. So then we, instead of so many biometric screenings, especially in August and September, being taken up in the clinics, we use the mobile units to do the biometric screenings and get a lot of that out. So that would allow us, the mobile units would allow us to take some of that growth that we might see in the 3 clinics, because you can only have so many appointments and you're done. And so that's what I'm getting at, is if you want to see where I'm going towards, I don't think you can go wrong with either one. I think they're both, I don't think you'll mess up either way. But if I'm looking for growth and I'm looking at Rutherford County, I think the mobile units will give us growth until we decide to either add another clinic or see what we want to do and go somewhere else. And if you want to do a psych nurse, then we can also come back and say, okay, we've got enough savings from what we've been paying in the last 2 or 3 years. There's enough there without spending an additional amount of money. Let's see if we can add that back in, and we'll come back to the committee and say, here's what we have. We know Vanderbilt's got 100,000. We're still under. So then we come back in and say, do you want to add a psych nurse? And do we want to amend the contract to add a psych nurse?
Listening to the school board's presentation Tuesday night, I believe it was, their 5-year plan is for 7 additional schools over the next 5 years. So that substantiates your concern about growth. I've got someplace I need to be at 4 o'clock. I'd like to put in a form of a motion that we, in essence, nominate, if that's the right word, both of these.
Select.
Have a roll call vote and let everyone say, this is who I want.
I'll accept that as a motion. Is there a second? Got a second from Preble? Any discussion? All right, you understand the process that we're getting ready to proceed with. It's going to be on roll call vote. Both have been nominated, so you're going to say, when your name's called, you'll say St. Thomas or Vanderbilt. Ready, Stacy?
Preble Acton. Rhonda Allen. Andre Anthony. Doug Bodery. Amber Brown. Shay Crowell. Holly Deering. Alan Farley. Mary Hickerson. Jeff Phillips. Shantae Sherrill. Eric Tutobeni.
We've got 4 for Vanderbilt, 8 for St. Thomas. I'll break the tie and go with St. Thomas. Looks like St. Thomas, that was Ed, go ahead.
So if I understand correctly, this goes back to purchasing with a recommendation from this committee that, looking at St. Thomas,
That's correct.
and then it'll go to the budget committee, and then it'll go on to the full
To
commission.
the full commission. You good with that, commissioners? You good with the process? Commissioner Allen?
Ed, and Jay, I'll leave this up to you. Would it be appropriate for me to make a motion for you to ask St. Thomas to consider adding the psych nurse piece to this and having them adjust their?
Yeah, I would.
Yeah, absolutely.
I'd like to make that motion that they add that to their bid.
Have a motion and a second to ask St. Thomas to add a psych nurse to their presentation, or to their bid? Eric, or Jeff? Yeah. All in favor of the motion, signify by saying aye. All opposed, motion carries. Thank you today for your due diligence. This was a tough one. I hate it that we have some so close, but I'm also think that we're blessed that we have good quality health care here in Middle Tennessee, and folks are wanting to take care of our employees. So I don't know what the next step is. We call them in or tell them to go home? Or? Okay. Vanderbilt went in and left? Okay. Well, that makes it easy. That's going to be hard to do, you know. But Jeff, if you need to go, but we're going to call. Thank you for your due diligence, and we'll call St. Thomas back in and tell them they've been awarded our contract subject to. It'll be a positive recommendation since this committee only votes for recommendations, positive or negative, and it'll be a recommend. Mary?
Mayor Ketron, as they're coming in, are we going to have answers to my county questions of how we're going to handle stuff? Will we have some better ideas next month? May not be some set in stone, but some better ideas of.
I've already looked at the calendar. September 1 is on a Tuesday, so, we would have a week and maybe an extra day to do that. I mean.
Gordon, would you mind, we've got a question for you, you and Christy. There was a question asked about the importance of having a psych nurse. Would that be possible, has a little bit of money to play with, would that be possible to put that into your bid if we paid for that?
Are you thinking as an RN or practitioner? Nurse practitioner. I know that we've got one on.
Understanding the importance of behavioral health these days, we would love to be able to offer that. Recruiting for those specialties is a challenge. So I would just say that, yes, if you've got money to play with, we would certainly assist in that recruitment process and be willing to bring them on board.
Okay, well, Gordon, it's the decision that has come from this committee, the insurance committee. They vote for a positive or negative recommendation, and they forward it on. The process will be that the decision here today will go to our purchasing committee. Then it will go to budget committee of the county commission, and then to the full 21 county commissioners. But I'd like to say congratulations that St. Thomas has been selected to be our partner, and we look forward to working with you and getting this off the ground and running. Is it the intent that everybody wants to go to phase 2? I'm seeing instead of starting with phase 1, I think everybody wants to see the availability of the Salem property in phase 2. We'd like to have that access of a Blackman is just, we need to haul Blackman off somewhere.
It's not that bad.
The last time I looked at it, it was. Okay, well, congratulations, Gordon.
Thank you. We certainly appreciate your consideration and look forward to moving forward.
And I guess next, we have purchasing committee, budget will be next week, and then full commission will be next week as well. So we'll have this all,
I have it written down somewhere. I'll give it.
it's on the calendar, but we'll have all this concluded and finalized for you, okay?
Thank you, Mayor.
Congratulations again.
Thank you.
Any other business to come for us today? Move to adjourn. We're adjourned.